Greetings, everyone, and thank you for joining with us on this beautiful afternoon at Quy Nhơn City. My name is Nguyễn Đăng Khoa. I will be your MC today. The Hsic Award was the Forum for Young Vietnamese Interventional Cardiologists for many years ago. Still, this year, we also welcome senior interventionists from Asia to come and share their deep knowledge. We also have 4 professional interventionists who will share their most challenging BCI cases in the third section. So stay with us till the end of the seminar and you will get precious knowledge from the leading specialists. So to begin, sadly to announce that Dr. Võ Thành Nhân and Dr. Nguyễn Thượng Nghĩa was due to the delay of the airline, so they cannot make it here in this afternoon. So I would like to introduce the other important panelists as our judges for the Hsic 2024 award. Please welcome to the stage Dr. Sozo Ishihara from Mimihara Hospital, Osaka, Japan. Welcome to the stage Dr. Lam Ho from Tuen Mun Hospital, Hong Kong. Please welcome to the stage Dr. Ngô Minh Hùng, Vice Head of Interventional Cardiology, Department Chợ Rẫy Hospital. Please welcome Dr. Panipa from Chiang Mai Faculty of Medicine from Thailand. Welcome all of you to the stage and become our panelists in this afternoon. Please welcome. Please take your seat. So we will begin, and with no more delay, let's start our session with the first presentation from Chợ Rẫy Hospital, entitled Optimal Timing and Choosing a MCS Device for a Cardiogenic Shock ACS Patient Undergoing High-Risk PCI. Please welcome Dr. Lý Quang Trang to the stage. And I will have a brief notification for all presenters in this afternoon that your presentation should not be more than 12 minutes. And after that, you will have 6 minutes to answer all of the questions from our panelists. Please welcome Dr. Chang.
So good afternoon, everyone. My name is Dr. Sang from Chợ Rẫy Hospital. It's very honor for me to stand here to present the case to all of you. So we have the 52-year-old male patient with chief complaint of chest pain, 16 hours before the mission. He had a severe chest pain accompanied by diaphoresis and dyspnea. All the symptoms were persistent and progressively intensified. So he went to the local hospital where the diagnosis of the cardiogenic shock due to myocardial infarction with a Whelan syndrome were made. So he received the treatment included vasopressor, antithrombotic, and statin before transfer to our centers. He exhibits any medical condition except smoking for 20 back years. Upon admission, his very pallor, cold extremities, high heart rate, low blood pressure with no adrenaline, and a normal oxygen saturation while under the mask. And then the condition deteriorated. He became severe hypotension. We have to escalate the dose of nonorine, and a severe respiratory distress. We have to endotracheal intubate and mechanical ventilate for him. So everything went serious and not easy for him right now. On the ECG, you can see the little elevation of ST from V1 to V4, and especially in ABR. On the laboratory test result, revealed elevated cardiac troponin, and the blood gas, you can see the metabolic acidosis with a very high lactate level. On the X-ray, you can see the diffuse growth glass opacity in a butterfly pattern indicated pulmonary edemas. But on an echo, we have the lobar left ventricular hyperkinesis with the AF just 14% and a TAPC just 14 millimeters, and no mechanical complication were observed. So we diagnosed this patient with the cardiogenic shock steady, biventricular dysfunction, and anterior STEMI 16 hours and kidney 4. So the revascularization strategy for this case, absolutely BCI first. In case the BCI not successful or failure, we can do BCI the patient will go to the CBZ, that's clearly. And only revascularize the correct lesion. But a big question raised about the necessity of MCF device. Even though the patient has no serious comorbidities, but with very low cardiac function accompanied by the problem of left band on the ECG, it raises concern about the risk of the BCI. This patient becomes very high risk. The risk of cardiac arrest, the risk of arrhythmias, or complication related to the procedures. So using an appropriate MCF prior to the BCI allow more time to safely perform optimal intervention for him. So in a cardiogenic shock, with MCF, we can raise the cardiac output, you can maintain organ perfusion, and raise the chance for myocardial recovery. So to do that, we have the various MCF devices with different effects on hemodynamics. Some dominantly support the right ventricle, some left ventricle, some support the both like the ECMO. In our center, we just have the ECMO, we just have the IBB, so which is optimal device we're going to choose for this patient? According to the shock state, when the shock deteriorated like this patient, we have to escalate the dose of vasopressors, we have to escalate the dose of inner trough, and with target organ hyperfusion, that's when we need to significantly raise the cardiac output. That's when the IBB no longer effective because it just provide a modest increase the cardiac index. That's when we need some device that provide a high flow like the ECMO, like the tandem heart, like the impeller. According to clinical scenario, this patient has the biventricular dysfunction. It's very important to mention the ECMO is the only device can provide biventricular support by just using a single device. So ECMO is the choice. So we need to know about the benefit and the risk we're going to face when you're using this device on the patient. The benefit, it clearly raises the cardiac power to provide hemodynamic protection during and after BCI. But about the risk, it's very important to mention that ECMO can increase the left ventricle after loss and the end-diastolic pressure, which it can worsen in myocardial ischemia, so which is a drawback in the patient suffering from cardiogenic shock. So to mitigate this concern, we can combine the ECMO with the other device, like the impeller, like the IBB to underload the left ventricle. So we talk about the evidence base. Evidence is about the ECOS shock, latest trial in 2023, about the role in ECMO with the patient with cardiogenic shock and myocardial infarction. This trial revealed that regardless of ECMO, the survival outcome of the patient didn't change. But it is disappointing in the result. I'm not so sure about this. We have some issue need to be reconsidered. First, the problem at times, most of the patients receive the ECMO after the revascularization, while before revascularization is thought to be more beneficial. Two, the problem of left ventricle underloading caused by the ECMOs, overloading caused by ECMO in a drawback in the patient suffering from cardiogenic shock. But just 5.8% in the ECMO group received the active left ventricle underloading, while this rate on the control group around 30%. Three, the problem of combined with other device. Up to 86% of the control group received the impeller CB. Everybody knows the impeller CB, the potential device, can improve survival outcome in the patient cardiogenic shock. Well, this rate on the ECMO group is 0. So all these problems raise the concern about can bias the result of this trial. Who's no? But what if can optimize this problem, make it change the story, make it change the survival outcome, like this study. With over 200 patients with cardiogenic shock due to AMI, the ECMO before revascularization show more beneficial compared with after revascularization. But ECMO before the BCI raised concern about the door to balloon time. The ECMO, when it started before the BCI, can delay the door to balloon time. But in this study, the ECMO before the BCI did not significantly increase the door to balloon time. So the benefit easily outweigh the risk. So back to our case. Following the consensus on the heart team, this patient underwent peripheral ECMO through the femoral venous arterial cannulation in the cath lab within 30 minutes before the BCI. And you can see the cannula already in an inferior vena cava, and after connect to the ECMO system, the interventional team will see the RCA angiogram. And you can see the 70 to 80% stenosis in RCA, in the middle segment of RCA, and 80% stenosis in BDA. But on the left side, even though it's matched our prediction from the beginning on ECG, it's very uncomfortable for us to see the total occlusion in the left main. So initially, we used the hydrophilic with subtip wire, vesicant wire to attempt to grow the lesion into the LD. But with multiple attempts, the wire just advanced to the circumflex and could enter to the LD. So we decided to advance this into the circumflex and use 2-by-0 balloon to perform the balloon angioplasty and lesion, hoping to restore the flow from the left main to the LD. It makes it easier to navigate in the Y. And after that, we escalate from the Western Y to the bilateral 50, but didn't work. So the difficulty in navigating the Y was unexpected. So it prolonged the procedural time. So imagine this situation without the support of VA ECMO. It raised concern about another potential outcomes could have been worse. So we continue to escalate from the bilateral 50 to the Guy second, and finally successfully go through the lesion and enter to the LD. And next, we use the balloon 2-by-0 for the lesion revaluation at the left main to the proximal LD, and this is the angiogram after the lesion revaluation, as you can see. So the lesion at distal left main near the bifurcation with significantly stenosis in the proximal LD and around 40 to 50% in osteum of circumflex. So the angle between the circumflex and LD is quite sharp. So it raised concern about circumflex when standing from the left main to the proximal LD. So we decided to adopt the proximal standing from the left main to the proximal LD and the gel balloon technique in circumflex to protect this branch. So we used the 3-by-0 24 dash from the left main to the proximal LD and the 2-by-0 balloon at the circumflex, as you can see. So after that, we both lighted it with a 3-by-5 NC balloon, and this is the final result, acceptable result with TME3 and no complication were observed. So after intervention, patient transferred to CCU for more ongoing recovery. So hemodynamic is made stable throughout the intervention and afterwards. After just 6 hours after the BCI, we successfully discontinued the vasopressors. On the 7th day, the ECMO will withdraw. And on the 8th day, the patient was extubated and went off the ventilators. And this is the follow-up echo, show that EF improved from the 40 to 36%. And the patient was discharged after 2 weeks with a stable condition and a stable hemodynamic. So after 1 month later, the patient came out with good condition, and the EF significantly improved to 43%, and a good cardiac result, cardiac boost. So through this case, we have something to mention. The V8 mode before the BCI can be more beneficial compared with the after BCI, and the heart team coordination is very important. And optimal patient selection and timing is the key to improve the outcome. Thank you for your attention.
So, question 6 minutes. Yes. Okay. Yeah, so congratulations for your case. So my question is, do you think that what is the cause that
Xin thông báo, báo cáo viên chỉ còn 2 phút trình bày. Xin cảm ơn.
You use a Versaturn and then pilot 50 and then with the guy a second. So the nature of the problem is because of what? It's a CTO or what is the cause? Since if it's just only the left main, like ACS, that should be the soft one. So do you expecting that there will be something beyond that? Do you consider to use intracoronary imaging to see the distal part of the vessel in this case?
Yeah, thank you for your comments and your question. So from the beginning, we thought the myocardial infarction and a cardiogenic shock. We think that's the lesion resembling a thrombus near the bifurcation of the left main, but is the difficulty navigating the Y across the lesion into the LD is what expected. We don't think about that. We don't just think it's thrombus easy to do the Y, but it's the harder, it's difficulty to navigate in the Y into across the lesion. Maybe this that thrombus, the reconstruction, or some kind of the new thrombus on the pre-existing calcified lesion. So to save the time tomorrow, to save the contract volume, we decided to escalate the Y from the beginning. But other option, we can use a microcatheter to more easily to navigate to the Y, another option. Yeah, thank you.
Okay, so very important point. So about the mechanical cardiac support, and so you, so even now, so the before so before revascularization or after revascularization, so mechanism, which is the best timing, is still controversial and discussion. You talk about that, and so this case, so hypertension, but still, so blood pressure is so there, so that. In my hospital or in Japan, so most hospitals are using IABP first. And so just for preparing ECMO. And if the patient collapsed at that time, so of course we quickly insert the ECMO. So that it's our, so maybe the Japanese style, so mechanical support. And also if some hospital can use impeller. Of course, it's also one option, but impeller is, as you know, very expensive. I think even in Vietnam, it is somehow limitation to use impeller. So that IABP is maybe, if the blood pressure is still low, but okay, at that time, IABP is first time still in Japan. How do you think about the role of IABP?
Yes, thank you for your comments. Everybody knows the most. Yes, IBB remains the most common use MCF for the patient suffering from coronary shock. Yeah, everybody knows it's easy to use, the low the cost, and effective some selected case. So just IBB just provide only the modest increase in cardiac index. So it's appropriate for the patient at the early state of shock, like the shock state A or state B, at a high risk of hemodynamic compromise. So when the shock deteriorated like this case, when it's steady, we need to some kind of significant raise the cardiac output, and IBB no longer effective. It just provide only low to moderate cardiac output. That's when the IBB is necessary for this. So, somehow can we combine the IBB2 and the ECMOs in order to the under low level? Because sometimes we did that. Yeah.
And also I have one more question. So that, for example, ECMO and impeller or ECMO and IVP, if we use both mechanical support, at that time we need two femoral approach. So we usually use PCI from radial, even the shock patient or so, for example, very complex case. So how do you think the approach? So PCI from femoral or PCI from radial, which is better for this kind of shock patient?
Yeah,
it's a guiding approach.
Yeah, in coronary shock is very critical. But some impellers, I think, is the most. Impellers is a very appropriate device in this case, but it's not available. It's in the most dangerous in the developed country in like Vietnam. So it's very. When the ECMO combined with the impeller, IBB can decrease the pulmonary or edema, so it can provide optimal support for hemodynamics for the patient. Yeah.
Maybe I just ask one short question. When will you consider to do the PCI on the RSA? When will you consider to do PCI on RSA? RSA.
Yes. After 1 month, patient came out with us for the revisit. So we, with a good condition and a stable hemodynamics, with the optimal pharmacotherapy, so we decided to complete revascular for the patient with the RCA. And we also do the repeat IVUS to re-evaluate the stenting of the left mantle proximal LD for optimized.
Thank you. That's a good point. Yeah.
Thank you.
So thank you for the outstanding presentation from Dr. Lý Quang Sang. So we will move to the next case. Please welcome Dr. Phan Anh Khoa from Huế Central Hospital with the presentation, the most expensive lesion in patients with multivessel disease and high ischemia risk. Please welcome.
Yeah. Hi everybody, ladies and gentlemen, it's an honor for me to stand here and introduce my presentation. The topic related to the multivessel disease and high ischemia risk. The this is my case. The case report about the 85 years old male with unstable angina. The patient have the medical history of the hypertension, control with medication, and hyperlipidemia. The presentation, clinical presentation is just new onset of the CCS3 of angina, and BMI was 24. The blood pressure is still normal, controlled by medication of blood pressure. And he has no prior CAD history. He's active, exercise, and have the normal ejection fraction on echo. The blood check is have a normal high sensitive troponin T, blood count, and normal the function of the renal. And ARC HBR is just 1 point. The patient was receive aspirin, clopidogrel, Vastar, Vancomycin, amlodipine, rosuvastatin, and Imdor. And we have a CA from January 33, revealed the calcified 3 vessel disease of 80 stenosis and the middle RCA, 50% stenosis is left main, multiple 80 to 95% calcified from proximal mid LAD, 99 calcified proximal LCX, and normal left ventricle ejection fraction. We calculate the SINGSTA score about 38, and after heart team discussion, the CABG declined, and because the patient declined it. Then patient was underwent PCI with the right coronary artery revascularization at after 2 days, and after 1 week, we do the rest. And this is the RCA. It's not too long and not too conservative patient in this picture, and we use the Buddy Y with the NC 2.75 balloon to prepare the lesions. And then we use 2 stents with 3.5 millimeter of diameter. But the middle is a little kinking, and we have to use a guide plus to support the stent manipulation. And then we have a NC, post-NC, and the final result here. Normally, we can see that this is a nice picture, and then we just stop here, and we don't do IVUS with this patient. And after a few days, we check the ECG is normal, improve the symptom. We have a normal creatinine and high sensitivity troponin T, and we have a new plan for the PCI with left main and LED LCX after about approximately 6 days after. And then this is the second revascularization strategy. You see, look at the left coronary artery is very heavy calcification here, and then we use 2Y to aortic and RCA, and you at least many balloon times of the LAD because it's very calcified and it cannot open the vessels. And after we have to use a NC 3.0 balloon that a little bit open better than pre-polarization. And then we check the angle again and use a stent with 3.75 diameter and 85 millimeter of length. And the second one is 3.5 millimeter of diameter and 40 millimeter of length. And then we require do the POT kissing balloon And then you do the last one of the LCX. Here, reopen again, and kicks in and final POT. This is the final picture of the RCA. It's look a little bit, it's okay, acceptable result. And we choose stop right here because it's very long time to do the publication with the 3 standard LCA. And how do you think about this picture? Is okay, or we can stop here, or anything else happen to the patient? How about us? We choose the option we stop here because there's too much time to do this strategy. But after 10 minutes, just 10 minutes, when we transfer the patient to the patient room, the patient got cardiac arrest. And we immediately transfer the patient, go back to the cath lab. And we don't know the reason why the patient got this complication. And then we do the both time chest compression and check the angiogram again. We see that the LCA have a slow TME, but don't have any total occlusion in the left coronary artery. But in the right coronary artery, you see the total occlusion in the right coronary artery. And we tried to reopen with the temporary pacemaker and do the PCI, but after 1 hour, 2 hours of resuscitation, we did not succeed, and the patient will fall. And this is one of the big nightmare of us. So what is the big lesson of in this patient? Is there a early in-stent thrombosis? Do the patient have the clopidogrel resistant? Or or when we do the LCA too much time and make the ejection fraction lower and make the RCA become worse and right immediately and have a total occlusion right on the bed. And so we deeply understand and try to figure out everything and have a big lessons through this case. And for us, is have a take-home message. This is my lessons. First, is patient with multiple vessel disease with a high ischemia risk. High ischemia risk in this patient is the patient got too much stent. We have a multiple vessel disease. We have too much stent. The total length of the stent over 16 millimeter. So we should. It's better to use ticagrelor. And then we have to do the state PCI. Is a preferable option, because if I do not do the LCA, the revascularization, it maybe patient still survive. It's just a total occlusion, but maybe some small channel of collateral channel go back to the RCA and patient just still survive. And we have to use IVERT to help eliminate the risk of a high ischemia risk patient. Thank you very much for your attention.
Just simple question, maybe I don't follow. So when the patient arrests, have you echo to see if you have any cardiac tamponade in this case?
Yes, we have an echo right here on the cath lab. And then we check, we don't have any cardiac tamponade or epicardial effusion after the PCI.
Okay,
yes.
And at that time, you don't see anything abnormal for the ECG in the inferior lead, like to the AVF?
Yes,
Xin thông báo,
I
báo
will
cáo viên chỉ
explain
còn 2
detail
phút trình
about
bày.
the
Xin
scenario
cảm ơn.
patient after cardiac arrest. Right after the patient got cardiac arrest, we transfer the patient and check compress to the patient, but we check the lung is still okay. But the patient have a asystole, so don't have any normal sign or ventricular AFib, VFib or yes.
Yeah.
So we try to use the pacemaker implantation temporarily.
Okay, because for me it's quite it's quite not, if it's acute stent thrombosis at the time, I mean right after you finish with the procedure with the left main, so that should be something that happened from the ECG, or it should be like with TVF arrest. But this is asystole, right? And the second one, because the clot is really long according to the angiogram. I'm not sure whether that's already happens since the very first day that you did the procedure. So I'm not sure whether at that time that's, because as you mentioned that you don't use the intravascular imaging, so it's difficult to say that you do not have a mechanical thing that is the cause, especially for the stent under expansion, since the lesion is done in heavy calcified lesion.
Yeah.
Thank you.
Yeah, thank you.
For this case, I think you're just unlucky. Yeah, because the patient during the procedure, you must already give heparin. Anticoagulant is enough. And then with DAPT, anticoagulant, and then the patient still have acute stent thrombosis. That's very unlucky. Yeah. Is it the case near the Lunar New Year?
Yes.
Yeah, that is the traditional wisdom. Usually for elderly, don't do the procedure in the big
Yes,
festival.
thank you very much.
Yeah.
Yes, it's one of the big experience. Yes.
Yeah, so do you think the possibility of the HIT, heparin-induced thrombocytopenia? Do you know the HIT? HIT. HIT.
HIT.
HIT, yes.
HIT.
Yes, it means so giving heparin, so it makes thrombus, so that heparin-induced thrombocytopenia.
Oh, yes.
It may be so possibility, but unfortunately, patient gone away. Yeah, so that it's difficult to check test or something. So that if you see the similar case, so not only the PCI related lesion or vessel, but also other side. This time you treat the RCA, but LCA, but also RCA you saw the thrombus both sides, so that it's sometimes due to the heparin-induced thrombocytopenia.
Yeah. Yes. Thank you. Yes, because the first procedure and the second procedure, the distance is about 6 days. Yeah.
Yes. So second time giving heparin or third time heparin giving is a very high risk. Yes.
Oh, yes. Yeah.
So thank you for the interesting presentation from Dr. Khoa. So before we go into our next presentation, I would like to introduce Professor Dr. Võ Thành Nhân, our chairman of this session today, the president of the Ho Chi Minh City Society of Interventional Cardiology. Please give Dr. Nhân a warm applause. I also introduce our co-chairman, Dr. Nguyễn Thượng Nghĩa, Vice President of Ho Chi Minh Society of Interventional Cardiology, Head of Interventional Cardiology Department, Chợ Rẫy Hospital. And I also introduce one of our most important panelists, Dr. Ngô Minh Hùng, Vice Head of Interventional Cardiology Department, Chợ Rẫy Hospital. And we will move on to our next interesting presentation. Please welcome Dr. Trần Văn Đông from Hanoi Heart Hospital with a presentation, CTO in the high tech of right coronary artery, how to overcome. Please welcome Dr. Dong.
Good morning, ladies and gentlemen. My name is Trần Văn Đông from Hanoi Heart Hospital, and thank you for giving me the second chance to being here to share with all of you my little experience regarding percutaneous coronary intervention. As we all know that our Mother Nature has unlimited creativity, and one of her creation sometimes made trouble for us. And in order to be successful in such a difficult case like that, we need to come back to some really basic principle, really basic law. So that is what I want to share with you today. My patient is a 61-year-old male patient, and he admitted to the hospital because of really typical angina and shortness of breath. His medical history is not so significant with prior LAD stent about 5 years ago. All of his echo and ECG and lab result is not so significant. But due to his typical symptoms, the patient was transferred to the cath lab for angiography. And here's the result. You can see that on the left side of the heart, there is only mild stenosis at the middle of the circumflex, and the stent at LAD is still patent. On different view, you can see some signs of collateral circulation from the right. And as we expected, there is quite a long CTO at the middle of the RCA. And if we only had the CTO itself, it is easy, it is straightforward. But when we consider a little bit further, you can see that there is some abnormal in the origin of the RCA. So, if you look in detail the ostium of the RCA, you can imagine that if I stand here at the ostium of the left main, then you need to go in front of me and up high, and then that is when you meet the ostium of the RCA. So, in such an anomalous origin of the RCA, what kind of guiding catheter should we use to support for the guide wire to successfully cross the lesion? Because my civil once said to me, if you want to have a successful PCI case, you need to have optimal access. And what is optimal access? Optimal access means peripheral access like femoral or radial, or central access like a good guiding catheter. And in such a difficult CTO case, you need to have a guiding catheter with both coaxial and optimal support. So this is not the first time I deal with a RCA anomalous. Sometimes it goes straight down, so just using some kind of guiding catheter like a multi-purpose is okay. Or sometimes the ostium of the RCA is just like, but not the same with that case. That when I use a AL1020, and sometimes I'm combining it with a extension guiding catheter, or sometimes I'm just using a GL40 is enough for all of the lesion. And on the word, when I'm searching for the experience of other authors with RCA anomalous and CTO in RCA, I found a little case. Because CTO with anomalous RCA like that is rare. And it's even rarer for an interventionist to be successfully done such a case. Well, American College of Cardiology write an instruction for interventionists to be choosing the right guiding catheter for each position of anomalous RCA origin. We know that, and with all of the experience from me and also from other authors in the world, I tried the first attempt to intervene this patient, but we failed. We fail with all the guiding that we use, such as a AL10, AL20, EBU 35, 445, or even EBU 5.0. We fail. I try to use such more complex technique like anchoring to the left main and then rotating the tip of the guiding catheter to the ostium of the RCA. But as you see that if you want to successful with that technique, the ostium of the left main and the ostium of the RCA must be on the same plan, like the picture above. But in our case, it's not like that. And even I try to push the guide wire to the small branch of the RCA itself to anchoring for the guiding catheter. I fail. And the reason I will tell you the later. But after we failed the first time, the patient was discharged. And then 3 months later, he came back to us. He said he really want for his RCA to be recanalized, and we was willing to accept the challenge. But this time, we think a little bit further and back to the most basic and principal thing in cardiology intervention. That is the connection between guiding catheter, lesion, and guide wire. It is inseparable. So that if the lesion is straightforward, sometimes you did not need to put your guiding catheter deep into the ostium of the vessel that you want to intervene. You just need to keep it touching each other, and then the guide wire will giving support for guiding stabilization. And if the lesion is challenging, you need the guiding catheter must be stable and support so that it can facilitate guide wire to cross the lesion. So, what is the necessary condition and what is the sufficient condition for intervention in this patient with, some kind of very distinctive feature? And the necessary condition here is a good support. At the first time, we tried to use every type of guiding catheter, and we found out that with the EBU 4.5, that only our hospital have, we have 2 backup points. But a good support is not enough because the tip of the guiding catheter is not back up. And every time you try to pushing the guide wire through the lesion or even push the guide wire to the side branch, there is a counterforce deflecting the guiding catheter. So that we fail. So how can we add another force to counter the counterforce here? That is what we're missing. So the sufficient condition is stabilization. Well, we have a EBU 4.5 here, and we add another element, that is a unplugged superstiff. A superstiff is straight, originally straight, and when you try to bend it over a small caliber of the ascending aorta, it will create an elastic force. It's trying to straighten up, and when it's trying to straighten up, it will create elastic force. And so the elastic force of the stiff wire will counter the elastic of the guiding catheter, and also it will kind of stick the guiding catheter to the aortic wall so that we have 3 or maybe 4 backup points, and the 4 right at the tip of the guiding catheter. So the guiding now was significantly stabilized and ready for intervention. And here is what we done in reality. With the stiff wire, you can see that the guiding is really strong. It stands still in the aortic, despite of the heart still beating. And with that stable, we successfully deploy a micro catheter, and then with a Gaia 2, we cross the lesion. But after we cross the lesion, the guide wire itself now is some kind of support for the guiding to keep it in place. And if we want to push the stent, push the balloon to complete the procedure, we need to remove the superstiff. Remove the superstiff meaning remove the support. So that we need another support here. So that easy, just using a small balloon and then push an extension guiding catheter like this, as you can see on the imaging. So with all of that, we were successful to deploy a stent, and this is the final result. So my take-home message for this case is there is no human-made devices, such as guiding catheter, that's suitable for all the diversity of the natural human anatomy. The guiding catheter were made for the majority, not for all. And in order to be successful in some distinctive and challenge case, you need to come back to the basics. You need to understanding and also utilizing the fundamental mechanism. And greatness is achieved not by complexity, but by mastering the simplicity. Thank you for your attention.
Okay, very nice case. And so using the stiff wire of 0.35 is very nice idea, yes. And so maybe guiding selection of anomaly of RCA origin is so maybe discuss so many literatures like so you already showed. And also, so you use the guide extension catheter. It's also very important option. But also, so for this case, there is a very big conus branch. So that balloon anchoring also very important. So the combination of balloon anchor and also guide extension is also very good for support. So first wire is easily advanced into the conus branch. So that using balloon anchor and the advanced guide extension, so that we can choose the next option. It's also one option. And another option is using double lumen catheter, like Crusade or something. So it's also the good support for penetration for CTO.
Yes. Actually, the step Y is the final choice for us because we fail with all other strategy. We try to using extension guiding catheter. We try to use anchoring balloon to the small branch of the RCA, but we fail to push the guide wire through the proximal of the RCA because the guiding is so unstable, and every time it's like oscillating in the back and forth in the ascending aorta with every heartbeat, so that we was able to approach the ostium of the RCA, but when we push the guide wire to the tip of the guiding deflected because the guiding is so unstable, so that every strategy like anchoring to the left main, anchoring to the small balloon, anchoring to the small branch of the RCA, we try but we fail, and so that's why we came up with the idea using step Y. Yeah.
I'm sorry, I asked you a question. In this patient, you use the femoral access or radial access?
In this patient, we use
the last
radial access.
Attempt, yes. And the femoral, yes.
Yeah, femoral.
This is the case with the lower origins of the RCA. And the origin originated abnormal. It go to the in the front and go down. So in this case, I think the best guidance you use is be the MP 1 with 3 or 1 or 2 or 3 up to you after you to try. In this case, you use the ABU.
ABU 4.5.
Yeah, 4. Yeah. After that, you make the curve.
Yes.
A curve go to the left.
Yes.
And go to the right.
Yes. Because right as the ostium, the RCA go up and then make a U-turn and then it go down. It's not go down straight from the start.
I understand.
If it's down slope right from the start, we can use AMB.
Yeah.
And I have so many cases with that MB before, yes, but in this case, it's not like that. It's go up and then down with a U-turn, yeah.
So it is not coaxial?
Yes, not coaxial at all,
yeah. When you try to do the CTO lesion like this in the RCA, yes. But you do the CTO lesion, intervention CTO lesion successfully.
Yes.
It's an interesting case, yeah.
Thank you.
If we still have time, I will say something about your case. Congratulations. This is the abnormality of the origin of the RCA. Actually, if the RCA is go to the left side, so it's better to use the left guiding catheter in order to get it in first. It's not coaxial at the first time, and you will put the wire in, and then you can use the balloon at the proximal RCA to coaxial the guiding again, or you use the extension guiding catheter.
Yeah.
Because it is not, I think they're not very tough CTO. Is it very easy to cross, but not very easy to engage the guiding catheter?
Yes.
Is it correct?
The CTO itself is not difficult, not so
yes.
difficult.
So the main point here is just the guiding catheter engagement.
Yes.
So we have to use the very gentle. Otherwise, you have to if you don't pay attention on engage the guiding catheter, you can cause a dissection, and that's very terrible in this situation.
Actually, when you're using such a stiff wire, like in my case, you have a risk of dissecting the aortic valve. Yes, so every move must be gentle. And we try using extension or anchoring before, but with this case, there is...
No, I just mentioning about
yes.
You just get engaged first, just close to the atrium of the RCA, and use the wire go in first, and use the balloon in order to direct the guy in. Without the balloon, you can cause the dissection.
The guy wire unable to, yes, thank you.
Okay, we will move to the next case. Thank you, Dr. Dong, for sharing your insights and innovative approach. So our next speaker is Dr. Trường Đình Phi from Vietnam National Heart Institute with a presentation about AMI due to SCAD, reperfusion or medical therapy. Please welcome Dr. Phi.
Good afternoon, ladies and gentlemen. I'm Dr. Trường Đình Phi from Vietnam National Heart Institute. I'm so glad to be here and share to everyone my case, a QMI due to scatter. So my patient is a 51-year-old female, previously healthy and employed as a nurse, has experienced sudden onset of severe left side chest pain during a night shift at the provincial hospital. Afterwards, she was transferred to our hospital, and her initial ECG indicated shift-based anterior MI with progressively increasing protein level. Her echo showed EF quite normal with apical hypokinesis. You can see her ECG at midnight. We showed a minor elevation at V1, V2, V3, and maybe V4. And in this context, we decided to do angiography at 3 a.m. We can see the RCA and circumflex are quite normal. But for LAD, we can see the acute total occlusion of distal LAD. And at that time, we made diagnosis with anterior STEMI with acute total occlusion of distal LAD. But at 3 a.m., we have a loss of question in the young female patient with no traditional atherosclerotic risk factor. What is the underlying cause or mechanism of this patient? In this context, it PCI indicated, or should we do the intravascular imaging, such as IVERT or OCD, for this patient? But, however, when we look closely at the characteristic of distal LAD lesion, we can see that the lesion distal LAD is gradually tapered and narrowed, relatively smooth, and then completely occluded. And in addition, on the side, I think it's extremely important to how to diagnose its damage of diagonal branch. We can see here. And now we can make diagnose a provisional diagnosis damage due to SCAD type 2B for LAD and type 2A for diagonal. In this context, I think next step, should we do PCI or do we do the intracoronary imaging to make sure the diagnosis? But I think that's be 3 a.m. and I think writing through the LAD is very difficult and maybe to extend the dissection of LAD. And in this context, the patient is quite stable and has experienced only mild chest pain. So that's we decide to defer the procedure and give the patient the optimal medical therapy with anticoagulant, enoxaparin, DAPT with luplavin, high-dose statin, beta blocker, and AEC inhibitor, and PPI also. And close monitoring to the patient in the hospital is very important and necessary. Simultaneously, we must look for the potential underlying cause with vascular assessment returning negative and normal lipid profile. We plan to do coronary angiography also in 1 week if the patient remains stable. And luckily, the patient remains always stable, has experienced mild chest pain on occasion, and her peak troponins reach about only 1,500. And when we do ECG every day, we notice that the ECG has started to be changed from day 3 with well inside. For me, I think that's a good side on ECG, because when we see this sign, it's almost certain that the LD has been revascularized. And indeed, when we performed the coronary angiography after a week, the distal LD was actually very clearly revascularized. And now, at that time, I think the wiring of LD is easy, and so that we decided to perform an IVR to confirm the diagnosis. Indeed, we clearly see the intramural hematoma limited above by the occlusion of diagonal 2. Afterwards, we maintain the optimal medical treatment, no PCI, and the patient has a discharge with the DPT, high-dose statin, ACE inhibitor, and beta blocker. The patient, we plan a coronary angiography in 3 months if the patient remains stable, and advise the patient to avoid heavy exertion and not on due to asthma because she's a nurse. And 3 months later, the patient come back with us with no more chest pain, but gastric pain a lot. And ECG seemed to have a completely returned to normal. And we did angiography schedule at 3 months. We find that the coronary artery is quite normal with completely healed the dissection of distal LAD. And we make sure we did again the IVR, which show a completely normal LD without any atherosclerosis. And after discharge, because it has no any atherosclerosis distal LAD, we decide to adjust the medication of the patient, initially therapy, including monotherapy, aspirin, beta blocker, ACE inhibitor, and PPI. But due to aspirin intolerance, gastric pain, the patient was switched to Plavix. But we have to stop Plavix also because it's intolerant also from the March 2024. And until now, the patient is stable, no chest pain, abdominal pain, the blood pressure and heart rate is okay. For this patient, we have some discussion. For diagnosis of SCAD require comprehensive evaluation focused on the characteristics of all the coronary artery branch. The IVR OST is good standard for diagnosing SCAD, but may not be considered in each specific case, like my case. Because I think for wiring for this LAD is very difficult and maybe extend, propagate the dissection. A SCAD with complete coronary artery occlusion does not require revascularization with the patient is stable, and SCAD is not in the high-risk location like left main or proximal LAD or may be life-threatening ventricular arrhythmias. And for almost K and my K also, the conservative treatment regimen remains controversial, but for my case, anticoagulant, antiplatelet, beta blocker, ACE inhibitor were beneficial. And for almost case, I think 70% SCAD, the etiology is not clear, and close monitoring and repeat coronary angiography and essential in the SCAD management. The timing should be individualized, with most SCAD cases resolving within 1-3 months. And if the SCAD has been recovered without evidence of atherosclerosis, we can consider stopping any antiplatelet drug and starting according to international recommendation, is not exact. But for this patient, the patient could intolerate to monotherapy. Even we have to stop even antiplatelet therapy. And post-SCAT physical activity guidelines should be discussed with a rehabilitation specialist to prevent recurrent. And I would like to share some key learning points from this case. We should be always vigilant and switch by SCAT young female patients with few or no cardiovascular risk factor. And we have to evaluate carefully all coronary artery branches to suggest the diagnosis of SCAT. Like this case, we found a lesion damage of diagonal 2. And IVOD OCT remains gold standard for definitive diagnosis of SCAT. And conservative treatment remains preferred strategy for almost cases. And patients need to be monitored closely during the hospitalization. Control coronary angiography need to be performed after 1 week before discharge and after 3 months to evaluate the progression of SCAT. And the cause of SCAT is frequently indeterminate. And finally, the physical regimen after SCAT is a key issue to prevent recurrence. Thank you very much for your attention.
So, congratulations, and I think it's really the best practice as you inhibit yourself not to do anything else. Because otherwise, it's mostly of us like, okay, slow fall, so let's do something. It's really like itchy hand. Anyway, so I think you show
Xin
us
thông báo,
the way
báo
to
cáo
do the
viên
best
chỉ còn 2
practice
phút
for
trình
this
bày.
patient.
Xin
So
cảm ơn.
just only a few questions regarding this case. Have you considered in this patient you should go for the workup for the fibromuscular dysplasia or not? So this is the first question, because mostly of the SCAT, sometimes we have to think about the FMD as well. And the second question is that, in your view, because for the consensus, you can use either IVOS and OCT, so which one you prefer, and what is your view about that, in using the intravascular imaging for the SCAT?
I think for the second question, because I think if the evidence is revascularized initially, I think it's important to do the intracoronary imaging to confirm the diagnosis. But this patient, the distal LVD is occluded completely. So I think that for wiring through the LED is very difficult, and at midnight, 3 a.m., there is very serious if we cannot mix wire into true lumen, and maybe the wire can't extend the digestion of LED. And I think and the patient, the most important is the patient is stable at that time when we can defer the procedure after.
Okay, maybe I ask 2 simple questions. How to decide the timing of restudy angiogram in this sort of case while you choose medical treatment? How to decide the timing?
I think for this patient, when we choose conservation strategy for this patient, we have to make the patients stay in the hospital and with very close monitoring, and I think it's depends on the state of the patient. Is patient stable in our center, and I saw almost international recommendation that we will control repeat coronary angiography after 5 or 7 days after MI.
And then is how to choose the modality of investigation. Will you choose CT angiogram or invasive angiogram after 3 months if the patient is asymptomatic?
I think when if we do only the multi-slide to see the lesion, the damage of LED is not enough, because maybe when I think the resolution of multi-slide is not enough, and when we do the coronarography directly the intra-coronary intra-LED, we can see more information for confirm, for make sure the extension or the progression of scatter.
And for more distinct, more advanced question,
Yeah.
how to choose between IVUS and OCT in this sort of situation?
I think the OCT is a good choice. I think an excellent choice for the patient with diagnosis of scatter, but OCT is not available in our center. And the more important, I think if the patient, if scatter has intimal tear, maybe with the OCT, when we inject, when we do injection, maybe the injection can't extend the dissection. And for me, I think IVUS is enough and safe for the patient.
Congratulations for a very interesting case. But I have a question for the older member of the panelists. After the first coronary angiography, personally, would you intervene or not intervene? Okay.
For the first case, depends on ECG, patient's symptom, and hemodynamic, and of course also angiogram. I mainly consider these 4 factors to decide intervene or not. If I intervene, usually it's just small balloon open, make sure there's a flow. If there's a flow and patient is okay, then we'll stop. And keep monitoring the patient in CCU. If there's no symptom, everything stable, then won't do restudy. Restudy usually should be performed at least 4 weeks later, if the patient is completely asymptomatic and stable. If you really want to do intervention, you need imaging to guide. It's very difficult to talk without the case to illustrate, because the major concept nowadays is not dissection. For the scab, in fact, most of the case I see is spontaneous hematoma formation. If you use OCT, you can see that the whole intima is completely intact. It's just spontaneous formation of hematoma. In this sort of case, sometimes you need cutting.
So this patient is a young lady, so that it is easy to understand this may be a SCAD or erosion MRI. So that maybe if it's too much distal, of course LA distal or RCA distal, we don't do PCI. But so relatively proximal part, we should consider doing PCIs. But so in this kind of situation, we should consider to use IVUS. Even in Asian countries, in Vietnam, in other countries, it is difficult to use IVUS because of the cost problem. But for this kind of case, IVUS is very important. And not putting stent is also very important because young lady. So that it's my opinion.
I would ask the question for the chairperson also. In this situation, in the final key message to the audience in this room, you give us that you leave it alone with the 100% occlusion of a very not very significant, not very important vessels. So in that situation, is it okay for the myocardium, the correspondent myocardium? I think that the myocardium has gone away. After 1 month, you check it up and you see that it's still, the vessel is patent at that moment, but at the acute phase, the myocardium already gone. So in this situation, you did the IVUS, and then you leave it alone because the hematoma, intramural hematoma. But the mechanical of this, the mechanical reason in this situation, it already is enlarged the lumen, compressed the lumen, and then it's make the TME flow already zero. So if you think that you leave it alone, it's okay for the patient or not? Because in this situation, I myself, I will do if I think that it is a SCAD, or I think the like a middle car, something like that, we can do this, use the small balloon in order to make it has some flow to the distal end first. And then we do the IVUS in order to make sure that you see intramural hematoma. Of course, intramural hematoma, we don't do anything for that because it's healing itself.
Yeah.
For a couple of weeks later. And I don't agree with you that you leave it alone with the timid zero flow in this situation because the myocardium already gone because we cannot save the myocardium without flow. Thank you.
Yeah, I think the most important is the patient is stable. He has experienced
Patient stable is not mean that the myocardium is still alive. That's my comment in this situation.
Yeah.
Because sometimes the myocardium, the corresponding myocardium, still alive because they're very lucky that they get the cholesterol from the opposite side. So, but I don't want to leave it this situation like if the patient lucky, you get the cholesterol from from this opposite side. Thank you.
Yeah, I have a question for you also because the patient doesn't interest to monotherapy, the antiplatelet event, and in my patient now, because I've seen the international recommendation for at least the patient after scatter, we have to use monotherapy antiplatelet, but the patient does not interested. So, what is your experience for this patient? We can stop for a long time antiplatelet, or we.
As an expert in IVUS and OCT, I would like to ask Dr. Panipa, what do you do if after the first coronary angiography?
In this case?
Yes, in this case. Thank you.
Yeah, I think during we see the OCT or IVUS, maybe you already see that the patient would have the plaque or not. If you see everything is clear, I would just put antiplatelet just only this short duration, maybe 4 weeks, because you are going to bring the patient back anyway. So it's clear, so it just stop because the patient will not have any benefit for prolong of the antiplatelet because you give antiplatelet just only to inhibit the platelet to go to the plaque. But if there's no plaque, I see no point to continue it.
Yeah, thank you.
For this case, I agree that OCT is very difficult because very distal the tube to the imaging part is very long, so you can't push to very distal. You cannot see it clearly. You need to use IVUS. Yes. Unless IVUS, you can't see clearly.
Not only this case, but for scanned case, it is difficult to remove the red blood cells, so that IVUS is recommended for scanned.
Sometimes IVUS cannot see clearly, and I do. This is some change of my whole concept in this few years. It's really you do more OCT and IVUS on those scabs, you find that some are really not dissection, no dissection, completely no dissection. The name scab is misleading. Most of the case actually is spontaneous formation of hematoma.
So all of you agree that in the first time, we will put a red wire through the lesion and then use the IVUS to see what is the mechanism of the occlusion. Mm-hmm. And if possible, we will use a small balloon to get the flow back. But what do you do if after ballooning, there is still an occlusion?
It depends on the imaging finding. If you see some dissection, then you are more comfortable just try to do more ballooning. Because you see dissection, sometimes the hematoma, the blood in the vessel can come out into the coronary. If it's a full intact hematoma, you balloon just make the hematoma move propagate. That is my experience.
So just ballooning, and if it's successful, it's a good chance for the patient. But the question is that if it's not successful.
Yeah. Another way which is not recommended by many experts, but I found it work is you wire and then go to very distal. You use double lumen catheter, inject a little bit contrast, then you will know the distal landing. And then in the distal landing, you put one small stent, because for distal, even you put one stent, even it's young patient, very distal AD, one stent is not an issue, it's just one stent. This stent, Gary Min said it cannot prevent the progression of hematoma, but at least it can prevent the progression of dissection. After one stent, I think at least it can increase some resistance so that the progression of hematoma is less easy. Then you can use bigger balloon to open and then to see if you can establish the flow. Yeah, because with the distal stent is more easy for you. And another thinking is to use some of the thinking if it's dissection, very, very severe dissection. You use imaging, you localize the place that is with severe dissection and is the entrance of the blood of the hematoma. I've seen someone said you just stent this part and then balloon and then it will be more easy for you to re-establish the flow.
Thank you.
There's some non-evidence-based way that I usually do before.
I think for me, because if from IVUS, I can see that where is the entry site and it's really no flow. Maybe I'll just stent just only the entry site and then wait. Yeah, just only the short one. You don't need to stent all the way because it's going to be the end of the procedure. And as we see from the IVUS, actually when the blood go out, it's just the vessel size go to 5 to 6, but actually the vessel size is just only 3 or 3.5. So if the IVUS can show you where is the entry site of the spontaneous coronary dissection, and you have no flow, just send at the entry site and then wait, just only to be patient of that. But if the lesion is let's say, to the left main, maybe you have to guard the surgeon back up as well, because sometimes we just cannot fix it. Yeah. So this is has written in the consensus in the ESC. So I think that should be the thing that we should know about that.
There's a guideline, a consensus published that you can refer to that, published by a lady, Malaysian lady, work in Canada or US.
Yeah.
Thank you so much. And now we have the last presenter for this session, Dr. Panupong Rota from Maharaj Nakhon Chiang Mai Hospital, Thailand. And the presentation is entitled PCI Puzzle in Cardiogenic Shock Unstoppable Tales.
Good afternoon, everyone. Good afternoon, Mr. Chairman and our panelists and every audience. I am Dr. Panupong Rota from Chiang Mai University. Today, I'll be presenting the challenging and complex PCI case. And I name it the PCI puzzle in cardiogenic shock and unstoppable tales. Let's dive into our case. She is a female, 68 years, and with underlying disease of hypertension and dyslipidemia. And she presents with a typical chest pain for 2 hours at the private hospital. And at the emergency department in the private hospital, she developed the cardiac arrest with VT 1 cycle and a PEA for 1 cycle, but she achieved the ROC after that. In the left-hand side is the first ECG before the cardiac arrest and showed generalized ST depressions and mild elevations is AVR, maybe lesions with enlargement, something like that. But the true ECG is a right-hand side after the cardiac arrest. The rhythm is a complete heart blocks, ST elevation in inferior and depressions in posterior wall. reciprocal in lead 1 and AVL. The acute inferior posterior wall STEMI with complete heart block is most likely at that time. Upon arrival to our hospital, the patient was in critical conditions with synod bradycardia and complete heart block. The rate is 30 beats per minute and unmeasurable blood pressure. We confirmed the bedside echo and no heart movement. And we immediately start the Lucas 3 chest compressions and transfer the patient to the cath lab. The medication before going to the cath lab is DAPT, aspirin plus ticagrelor, and inotrope is NOI and dopamine. As we began the procedure, I point to most likely the culprit lesion. I point to the RCA. I also insert the right femoral and right artery and vein sheath and insert the transvenous pacing tube. I try a lot to engage of the RCA with JR4, take time about 8 minutes, and I can find nothing. And I change to the JL4 to see the left hand side to the left coronary artery, but the flow is very, very sluggish because she has no heart movement due to cardiac arrest. And the rhythm during PCI procedure is a PEA at 8 minutes. And for sure, the choice in our hospital right now is the ECMO, and we activate the ECMO team. But the ECMO in our ECMO team, the CVT surgeon is still in the OR for emergency case too. During waiting for the ECMO team, I try to engage again with the AL1, and I try for 25 minutes to find the RCA or the abnormal origins of RCA or something like that can explain our cause of cardiac arrest in these patients, but I can find nothing too. And after the CVT comes and insert the ECMO, okay, it has come, the situation is better than previous. I try again with the JR4 to engage the RCA, and I find nothing again. And I change to the AL1 again to find the RCA in the right hand, in the right coronary cusp, and I find nothing. But in the left hand side, I see something a little bit sluggish. You see it in the distal, very distal of the left circumflex. Maybe I see the flow, but the catheter is non-selective. And I change to the JL4 again. For the left circumflex, you will see the proximal left circumflex 90% stenosis, and the LAD is CTO, the LAD. But you see the collateral to RCA. The possibility is two things. One thing is a patient had a CTO RCA and with the collateral branch from distal RCA. And I changed angulation to the alveolar cranial view. I saw the tapering branch from the distal left circumflex to the RCA. That the vessel caliber is tapering. At that time, I think that, maybe patient are absent the RCA. That my first get okay. Okay, and then I try PCI to the proximal circumflex first. I pre-dilate with a SC balloon to 2/20 and put the stent in SES stent 3/28 and post-dilatation. And this is the angiogram after we PCI at the proximal circumflex. Everyone happy with the result, right? Because patient have the cardiogenic shock. And right now, the patient have no malignant arrhythmia. After ECMO, the BP is 96/65. And she's a little bit awake at E3, V2, and M5. And the contrast volume are not record right now. But the ECG and the inferior is a little bit elevated. But we should stop the procedure, right? But in this case, I continue to do it. Then I wide to the distal, very distal of the acute marginal branch. It acts from the left circumflex, and I pull out with small balloons. And the right hand side is the angiography after pull bar. And I still POBA on the upper branch of the RCA2. And should be finished right now. We get happy, everyone happy with the result. But right now, at that time, I'm continue PCI to the CTO LAD. At that time, I think that just touch a little bit. If that Y is stuck or it can't continue, I will stop. But the Y is feel the XTA and Y very, very easily into the distal LAD. And after POBA of the LAD, you see some recoiled segments of the LAD at the proximal and the mid. And then, sure, I decide to put the stent in the LAD from the distal to the proximal to the osteo LAD. And facilitation. And this is a final Korean angiogram in these patients. Finally, I PCI as I put the stent in the proximal circumflex, POBA on the distal, very, very distal circumflex, and put the stent from the osteo LAD to the distal LAD. But unfortunately, we lost the side branch of the DG1. Okay, and that time the patient have no malignant arrhythmia. BP may improve a little bit, 100 over 75, and she fully awake right now. The total contrast volume is 320. And patient admit to the CCU in our hospital, and you compare in day 0 of echocardiogram, you see the ejection fractions is around 10 or 15, but in day 5 of the patients, the heart functions it improved a little bit, and the ECMO setting it a little bit of vein of it. But unfortunately, she passed away because she have very massive of left hemothorax. So the conclusions in these patients, first one is anomalous Korean origin should be always considered. Maybe incidence is less than 1% in the absence RCA in general populations. And the second one, in hospital, extracorporeal CPR or the eCPR is very useful for facilitated hemodynamics and PCI procedure and can be life-saving doctor and patient in critical situations. The important thing is the complete revascularization should be avoided in patients with a cardiogenic shock, the evidence from the culprit shock. But we have a small observation study in patients with a suspect ongoing ischemia. Maybe PCI in non-culprit branch may be facilitated weaning off the ECMO. But the final conclusion is very important for me is you know when to fall in. That means you should know when to quit and stop the procedure. Thank you for your attention.
May I ask, where did you put the ECMO? Is it in the cath lab or outside the cath lab?
Inside the cath lab.
Inside the cath
okay.
lab. And for this case, will you consider add on one more IBP? Because sometimes ECMO compare with ECMO plus IBPs, sometimes plus IBP may work better.
Yeah. Because in general in our hospital we generally use IABP, but in this patient, the patient has a cardiac arrest since she appears to arrive to the hospital. I'm afraid that if I put IABP at that time, maybe it's not work or it's not sufficient to support of the hemodynamic at that time.
I mean add-on therapy.
Add-on therapy.
Add-on therapy. ECMO plus IBP. Will you add on IBP?
In this case, or in my opinion?
Yeah.
I think it's better, but at that time, I'm not sure about the route of the access sites because they access both of the groin. We do PCI via the right femoral artery, but we put ECMO on the left side. But I'm not sure that where should we insert the proper side of the IABP. And in the literature review, combine the ECMO with IABP is maybe optimized PCI is better and facilitate to EC PCI.
Okay, so maybe the fast using ECMO is important choice as you said. So and after the PCI, so using ECMO and also after PCI from right femoral, so we can choose the Cs from PCI guide to the IABP. So using ECMO and IABP is also one option to reduce heart stress, and it's one option. So maybe Dr. Hall also say.
And then nowadays, hemodynamic is very popular. So in this sort of case, in post-op care, will you consider hemodynamic assessment to guide your therapy? For example, white heart cath, cardiac output, CPO, etc.
You mean CTO?
White heart cath for the wedge, for the cardiac output, cardiac index, cardiac power output, all this hemodynamic assessment, which is quite popular recently. Of course, not evidence-based. Just ask query, will you consider all this hemodynamic assessment for those complex trip after procedure?
To be honest, in our hospital, we're not a routine to do the cardiac, the invasive cardiac monitoring, but it's a good point because I think it's in every literature it's very important to monitor, like you said, but in our hospital, not routinely.
Not a problem because we also not routinely do it. Just nowadays, it's a trend. People like to do it only.
In this patient, at the emergency room, when the heart rate go down, you don't push the pacemaker pulmonary or not?
I put pacemaker on the cath lab because we the cath labs we have a cath lab and behind the ER. In our hospital.
From the heart rate go down, go to the patient cardiac arrest. How long?
How long?
How long? Yes.
I think less than 10 minutes.
10 minutes.
Less than 10 minutes.
Very quick, yeah. You do the CPR.
Yes.
With the machine.
Yes, machine.
The cath lab is behind the ER.
I have a question for you. How did you realize that the left side is the culprit lesion? Because usually we do the cranial and then we suspect something from the left side. Otherwise, it took quite a long time to find the RCA. Where is the RCA? And that's the moment that we waste time. We waste time a lot, so we have to quickly realize that the left side, the left dominant is the one, like the circumflex. So usually we go to the left cranial angle view, and then we suspect, and then we just quickly. Because in this situation, I think that the time is very important because if we slow to open the circumflex, so maybe we cannot save the patient's life. Thank you.
In fact, your case is very interesting and very rare for every operator because while the patient on Lucas and then you try to engage the guiding catheter and then do the PCI, which is not common. So in your experience, can you give some tips? Which view will be better to do the, I'll say, which view will be better to do the LAD? Because while Lucas is on top, you can't use the usual view.
Actually, but because you mentioned the machines is a very limited angulations. At that time, I used the LAO view and a little bit of cranial view, maybe facilitated, but from the machine is still limited to angulate because we have a very long distance between the projection to the patients. But LAO cranial may be better in that time.
Oh, thank you so much for your interesting case. And On behalf of all the panelists, I would like to thank all the presenters and everyone who participated in the first session of the Hsic Award. And I hope you found the session meaningful and engaging. And we will move on to the second session. Thank you. everyone. We will start the second session with almost 30 minutes like behind schedule. And may I introduce, next to my right is Dr. Kan from Kyungyang General Hospital. To my left is Dr. Lam Ho from Hong Kong. Professor Phạm Mạnh Hùng from the Vietnam National Heart Center. Dr. Panipa from Thailand. Dr. Đinh Đức Huy from Tâm Đức Hospital. And may I introduce the first presenter, Dr. Nguyễn Bích Diễm, with the presentation entitled Complication During Staged PCI. How should we treat? Switch the agenda.
Good afternoon, everyone. Good afternoon, Mr. Chairman and panelists. And I am Dr. Bích Diễm, come from Heart Institute of Ho Chi Minh City. Today, I will present a case report about the complication during stage BCI. I was not successful in management this complication, but with the spirit of learning from sharing. So I want to share this case for everyone to learn how should we treat when we face with this complication again. And my patient is a female of 74 years old and patient with a history of unstable angina, CAG, so free vessel disease. Patient was BCI with 1 DES in LAD and 1 DES in RCA and still have significant stenosis in proximal circumflex. The patient was present with a worsening chest band and started with 4 days before examination was no abnormal. The echocardiography showed that hypokinesia in inferior ward and EF about 56%. The turbulence was under 14. And this is ECG showed that the signus rim and the Bohr R wave progressive progression in D2, D3, and EVF. And the CAG 1 month ago showed the free vessel disease. As you can see on CTO in LAD and significant stenosis in circumflex and proximal of RCA. The patient was treated with 1 DES in proximal RCA and 1 DES to ostium to middle LAD, and the plan is to stage BCI to proximal circumflex. And with this patient, we take elective CAG for this time. The CAG showed that no restenosis in previous stand in LAD and proximal RCA, and black in circumflex is about 70 to 80%. And with this patient, we plan to BCI the proximal circumflex with direct stenting technique by 1 DES, 1.75, 18 to proximal circumflex. But we could not push the stent through the ostium of circumflex. So we have to pre-dilate with a balloon 2.5 15 millimeter, and the problem occurred here. We could not retrieve the balloon catheter to the guiding. And you know the cause of the balloon entrapment in the vessel. Maybe the balloon failure to deflate, or the balloon fracture, or the balloon interact with prior stent. And after we check on the system, on the B-side system, we find out the reason is the balloon was stuck in the stent tube in ostium LED. And now, what should we do for this patient? The patient statement right now was stable. And we have more technique to withdraw the balloon entrap in the vessel. But in this case, the balloon entrap in the stent tube. So we don't know how to do with this case. And the one thing we can do is trying to pull the balloon back, and because it is the first time that we face with this complication, so we feel a little bit nervous. So we are losing the Y in circumflex, and this makes more difficult for us to solve this problem more and more difficult. As you can see, when the Y still in circumflex, is the balloon will straight and go answer to the vessel. But when we're losing Y, the balloon will a little bit folded. So we have more difficult when we pull it back. And the patient statement right now, the blood pressure slightly decreased. Now we call for help from a surgeon, from anesthetist, and other staff in cath lab. The only one thing we can do right now is continue to withdraw the balloon. We use another wire to LD and another wire to marginal, and one NC balloon in left main LED to anchor the whole system for pull the balloon back. And when we made more attempt to pull the balloon back to the guiding, the effect on stent LED maybe it makes stent LED deformation. And in this situation, when we can withdraw the balloon into the left main and guiding catheter, we find out something abnormal in left main and guiding catheter, as you can see that. And when we withdraw on the system, we cannot withdraw on the system, and we see this picture. The balloon still entrapped in the stent, and the proximal spark of the stent got deformation, as you can see. And right now we have a heart team consultation and decided to emergency surgery. At the operation room, the patient was CBG with 2 bypass graft and open the aortic to cut the deformed stent and withdraw on the system. And this is the real picture we can see about the complication. The balloon was stuck in the stent tube and stent deformation. The patient was, after that, the patient was stable, and the patient was started DBT after 2 days when the bleeding was controlled. And fortunately, the patient was discharged after nearly 2 weeks and feel better until now. And when the patient was safely, we check on the procedure that we made for patient, and we find out some problem that we made for my patient. The first one is when we do the first phase strategy, we do the PCI in ostium LED, why we have a significant lesion in circumflex need to be PCI. And the second one, when we putting stent in ostium LED, we made the stent protrude into the left main a little bit more, but we don't identify. The third one is we cannot recognize when the wire passing through the stent tooth when we go the wire to circumflex. And the fourth one, when we feel so nervous, we loosen the wire in circumflex. And last but not least, but is should we stop and get help from surgeon early? After all, there is some discussion for this complication that we have stuck balloon in the coronary artery, especially stuck in the stent tooth, is a very rare complication. But if it happens, it can lead to the life-threatening complication. The most effective treatment for us is prevention before it happens. And in patients with multivessel disease, especially with LED or circumflex ostium lesion, we should choose the appropriate first phase PCI strategy. We should base attention for the feeling when we go the wire to the vessel, so we can early identify why the wire passing through something abnormal. And last one is a very important thing when we face with any complication is to keep calm. That's all for my presentation. Thanks for your attention.
I think this is a very challenging situation. Yeah, like what you said, prevention is the most important. But once it happened, it's also my first time to see. I haven't encountered this complication before. Difficult to think about any solution. I just see your case and then think about some suggestion. Is we sometimes, if we cannot push the balloon in the side branch, we use anchor balloon. So if we put the wire in the AD, do anchor balloon with anchor balloon and then pull, will it give better force to pull the balloon out? Do you understand? Anchor balloon in AD stand first and then pull. You may not be able to pull it completely out, but maybe just partially, and then inflate the balloon, then destroy the stent struct. Then maybe it will be easier for you to pull it out. Or how about the others? Can you think about any better way?
So I think in other ways. So if I got this problem, of course, even we use IVUS, we know that this already like go beyond, or it's like strut and then under strut and then strut again. It's really difficult. But I just thinking that maybe if I were you, I would do the pot first, because you already figure out that it's already like beyond the osteo. And then do the pot and see if the strut is going to be like wider, and then just cut the distal of the balloon and use a geisila.
Yeah.
And then like move the geisila really close to the strut, and then I'll try to pull it out. Yeah. So any other idea?
Yeah, I think it's more important that we have some more support. So I think the anchor balloon in LED, and then try to push a guide plus, maybe a very good small catheter in very close to the balloon, and then do port for the very proximal of the stent. Hopefully that we can make the strut becomes bigger, and then the balloon can come out. Yeah. But the most important is, I think we have to keep the wire in. Yeah, when you lose the wire, then you lose everything. You have no more chance to get the stuck balloon out.
Thank you, Doctor. Thank you, Dr. Pui. Yes, sir. Okay. Actually, I have one case a little bit similar with this case before, but on the ostium of the Hsic, when one of my colleagues to try to do and they cannot put back whole thing, including the balloon. So as I think I do another puncture to have a second guiding. It's a bigger, and I try to do something similar to somewhat you retrieve the lead when you want to retrieve the lead. So I try to push a larger guiding to push to hold the awesome of the Hsic, and then we try to pull out the balloon from the first guiding. So I successful with that case. But in this case, I think we can do the second guiding catheter, and we can try to push one balloon in the stand of the LED to do something like an encore, and we try to do. And other way, I think we try another thing to wire again to LCH to try to go in the same thrust, and then using the second balloon to inflation. But the more important thing, I think we need to the second guiding to manage it. So this is my experience. Yeah, thank you.
I think that the first thing to do before deleting the start of the stent is that we will push the balloon forward, and then we will use the technique of refolding the balloon, meaning that we will use slow pressure for example, 4 atmosphere, and then deflect it rapidly so that the profile of the balloon will be smaller than after the inflation, and then we may take it back, pull it back before trying to put a second guide wire, and then using a second balloon to open the stent slot.
Difficult case, and I feel this situation. So the patient had stand in the proximal LD. So when we do the PCI in the proximal circumflex, you make sure the drug stand not cover the osteo circumflex with the imaging. For example, the OCT, or you zoom in the angiogram to bigger, and you make sure the stand track not cover the osteo circumflex before you do the PCI to circumflex. And your situation, I think, difficult for us. Thank you.
So maybe I ask the presenter some more challenging question. For example, NC track, the balloon NC track. Do you know what is the response of the NC balloon while you pull it? Did you try it before? You mean pull the NC balloon? What will happen?
I cannot.
You don't know. Oh, okay. There's one more tips and tricks to share. Usually in this situation, you need to open the same band of the NC balloon and then try to pull to do one experiment for you to feel what is the maximum force that you can give. Sometimes you can pull, and then with certain force the balloon can break. Some of the balloon will not break, they will elongate and then break. Different depends on the band. For example, NC track will elongate a bit, a certain part, and then break. Some of the NC balloon you just pull and then it will break at the junction. So while you pull, it's better to open a same band, same NC, and try the force. Make sure you don't do higher than the expected force. Otherwise, the NC balloon will break. Yeah.
I think that we can also use a guide extension to facilitate the withdrawal of the balloon after trying to refold the balloon.
Okay, so thank you so much. So I think we move to the next presentation. I would like to invite Dr. Nguyễn Viết Lâm.
Good afternoon, ladies and gentlemen. My name is Lam from Hsic Central Hospital. Today I am very honored to be here when I am participating in SSIC 2024. And now I am introduced about my case about no reflow phenomenon. And no reflow phenomenon is a serious complication that occurs after opening of an infiltrated artery that results in a worse outcome. And about definitions, angiographic no reflow defined as a less than TIMI-free flows. And about pathophysiology, there are two main factors contributing to pathophysiology: is distal embolization, cardiomyocytes, and ischemia reperfusion, and the last is the individual susceptibilities. And how to deal with the no reflow phenomenon? First, we are exclude the north cause, check HT and hemodynamics. And the next step, we balance the vasodilator agent via a delivery system. And I had my case today, a 70-year-old female patient was admitted with angina and dyspnea. About medical history, she has a type 2 diabetes and hypertension, and a vital sign was normal. And ECG showed that ST assessment elevation in D2, D3, and AVF. And ST assessment depression in D1 and AVLs. About echocardiography research showed that the hyperkinesis of the anterior walls and EFs about 42%. A laboratory test was with elevated Hsic. And she was diagnosed posterior STEMIs, Mills EF has failure, type 2 diabetes, and treatment with aspirin, ticagrelor, rosuvastatin, dapagliflozin, perindopril, and enoxaparin. And this patient was indicated for emergency PCIs. About coronary angiography, so that's about coronary angiography, so that lemon have a 40 to 34 to 40% stereo, and LD, so that's subocclusion of the proximal, and 90% stereo at proximal diagonal, and LC has a mu stereo of ostium. And about RCA, so that 95% of distal segment before the bifurcations provides collateral circulation to the LEDs. And so what should I do for this case? And my team decided to perform a copious artery besides RCAs. We are perform a pre-dilation with semi-compliance and stenting with stent 2.75 mm. And angiography, after that, you can see that's a TME flow about 0 to 1. And the patient has a severe chest pain, blood pressure drops. And on the monitoring show that the third degree AV blocks. And this patient was that no referral phenomenon. Immediately, we are intervened about atropine, dobutamine, and norepinephrine interventions, and bolus of nitroglycerin and epinephrine via guiding catheter. And after 1 minute angiography, so that TME flow not improve. So my team deciding perforated balloon techniques for this case. And how to do a perforated balloon techniques? We choose a semi-compliant balloon with a diameter about 2.5 mm or larger, and after an inflated balloon with a normal saline, and after inflated, we 6 to 10 how was been by using a micropuncture needle as the balloons. And the next step, we push the balloon to the distal of RCH and plus of nitroglycerin and epinephrine injection in the distal RCH using a perforated balloon. And this research angiography after 5 minutes. You can see TME flows. However, the patient still angina persistent and unstable hemodynamics. And my team decided to LAD size. About LD size, we are using a guiding EBU, guiding a filter, and run through, and lesion prepared with a semi-compliant 2.5 mm and 2.0 mm, and non-compliant 2.5 mm. And next step, we are stenting at the LD with a middle LD stand 2.5 mm and proximal LD to the osteo of LD with stand 2.0 mm. And angiography so that no flow of LDs. And we are continue using user perforated balloon techniques for the LEDs. And after 5 minutes, you can see the TME flow was improved, and this TME 3 flow of LD. And after 7 days, we are angiographies, and the angiography so that's a 75 osteomorph stenoverb LC complex. And my team decided to plan left main LD stenting with a stent 3.0 mm and kissing balloon with NC 2.0 and 3.0 and 2.75 mm, and POT with NC 2.0 mm, and the final angiogram with a good results. And I have a conclusion. Coronary flow is frequent occurring during PCI in the setting of STEMI. Prevention and treatment are paramount important because of full benefit of reperfusion is recognized. Only coronary flow is normal, and perforated balloon technique was a rapid, safe, and effective method to deal with no refill phenomenon. That's all my presentation. Thank you for listening.
Thank you so much, Dr. Nguyễn Viết Lâm, for very interesting case. especially for the tip of the handmade perfusion balloon. So it is very important learning point here. So you can do the handmade perfusion balloon in a case you want to deliver the drug to the distant parts of the coronary. So may I ask our panelists a question or comments about the case?
Yeah, may I have a question? So, have you checked with imaging that there is no dissection from the proximal or distal end of the stent, just when you recognize the no reflow phenomenon?
Yes. At the moment, the IVUS mechanism has no problem, and I cannot do IVUS in this moment, and do not check the dissection in the stent. However, after injection of nitroglycerin and epinephrine, the TIMI flow was improved, and I think it's a no reflow phenomenon in this case.
May I ask the question about the drug that you use for the no reflow? I see you use adrenaline plus TNT. So why will you choose this combination? Because some papers said TNT had no effect on no reflow.
Can you repeat the question?
I see you had used the two drugs for the treatment of no reflow. One is adrenaline, and the other one is TNT, nitroglycerin. So why will you choose these two drugs?
Nitroglycerin in this case. In this case, because of this patient has no reflows in the distal of RCAs, and I have used dobutamine and norepinephrine to stable hemodynamics, and after that I have a little of nitroglycerin to distal RCA to improve the flow inflow of RCAs.
Okay, thank you.
Yeah.
Thank you. So I also one question. So why you decide to do for the left side with a very complex PCI in the same procedure?
Yes.
Very interesting. Yeah. Do you think it can increase the risk for the patient when you decide to do the very complex PCI for the left side?
Yes.
I have one question for you.
Yes. This patient was diagnosed STEMI in inferior STEMIs, and the Cupid's artery is RCAs. And after we performed the RCA PCIs, this patient was not improved about angiomas, and hemodynamics is not unstable. And because of RCA, because of LED is subocclusion of the proximal and receive collateral from RCA, and so after RCA PCI we has no reflows, and I think the flow collateral from the RCA is decrease in this case, and so my team decided to LD PCI in this case.
Thank you. I have a question for you. For the artery nose flow, after you inject the nitroglycerin IC into the distal RCA. If fail, what should we do?
Yes.
Next step.
Yes. If fail with nitroglycerin, I will try the plus nitroglycerin repeats or plus other agent vasodilators such as epinephrine. Yes, and because and in this case, patient have a bradycardia and with a third degree AV blocks and cannot and this and contraindication for the adenosine. Yes. In another case, maybe using adenosine for the no reflux anonymous. And in the and maybe repeat the vasodilator agent and following about 5 to 10 minutes and angiography to detect the flow after that.
So just only one question.
Yes.
So how can you be sure that the patient still got a chest pain? Because the problem because of the distal embolization that you do for the RCA is not because of the LAD, because LAD is a CTO, right? Yeah. So even it has been a long time. So how can you differentiate it? And the second one is, are you were you consider to use the IABP and
yes.
in this case, because you already restore the flow.
Yes.
And another one is not the question, but is my comment. So mostly if I have such a problem in my cath lab,
yes.
I don't do the perforate balloon because we are getting old, so the eyesight is not good. So I use the thrombuster instead, and then I use a nitroprusside, and then go to the distal, and then do the injection, the pullback, so you can check the flow and check if any dissection or clot is the same time. So
yes.
Yeah.
Okay. It's in my opinions in this case, after the reflow of RCAs, the TB flow was improved because of RCA provide collateral to the LAD and no reflows of RCA, so should not be the decreased flow of LD flow to collateral to LD, and so my team decided to perform the LD PCIs, and the perforated balloon techniques is a very effective for the poor patient in Vietnam because of it's reduce the cost for the patients. And about in this case, I think maybe using EABP for this case. Yes, because in my cath lab it's not EABP not available in my cath labs because of EABP is performed on a CCU.
In your presentation, I saw that there is an ST elevation on D2, D3, and AVF, meaning that the complete lesion is on the RCA. So what happens to the ECG after you put a stent in the RCA?
Yes. After stenting with RCAs, the ECG blocks the third degree AV blocks on ECG after stenting of RCAs in the distal.
Is there any modification of the ST elevation after the stent?
Yes.
after the stent in the RCA.
Yes.
Is there any modification of the ST elevation in the 2 D3 AVF?
After stenting in the RCA, the ST elevation is not decrease the amplitude, and however the ECG on monitor so that the third AV blocks after that. And after we are treatment no reflow, the rhythm is not synonymous.
Okay, thank you for your presentation. And now we move to the third presentation. Successful PCI of left main dissection following mechanical aortic valve replacement surgery from Dr. Dương Thiên Bảo.
So thanks for having me here today. My name is Bảo. I'm from the Interventional Cardiology Department at the EMC. So today I present to you, So today I present to you a 65-year-old female patient with the history of mechanical aortic and mitral valve replacement surgery due to rheumatic heart disease 20 years ago. The patient also had permanent AFib and was on the daily treatment of the VKA and the beta blockers. She was complaining about the exertional dyspnea for 1 month and was admitted to our hospital. Physical examination at the beginning showed that the patient was in stable conditions with systolic murmur at the left side of the sternum. All the lab tests was in normal range with a slightly increase in BNB level above 300 and the poor R-wave progressions and T-wave inversions in V2 to V6 on the EKG. The echocardiography showed that the patient had the normal LV functions with proper positions and functions of tricuspid and mitral valve. However, there was a severe stenosis of the aortic valve with the mean pressure gradient and the maximum velocity across the valve was 52 and then 4.88 meters per second, respectively. So the diagnosis at this point were the severe symptomatic restenosis of mechanical aortic valve, and the indications for aortic valve replacement surgery was recommended for this patient. So the patient underwent the surgery, which lasts for the total of 10 hours, 30 minutes. Opening the ascending aorta, we identified the main etiology for the stenosis, which is the panus. So the previous mechanical valve was replaced by the Onis valve site 21. Unfortunately, immediately after we release of the aortic clamp and in the airing of the left ventricle, the patient suddenly developed the ventricular fibrillations and required 3 times of defibrillations. And although all of that, the patient's hemodynamic status were unstable and required a high dose of vasopressor. So the surgery team came up with the diagnosis of the ventricular tachycardia that's secondary to the myocardial infarctions. So they decided to utilize the right saphenous vein and perform the CBG with the 2 bypass from the aorta to the LAD and the RCA with the IIPP as the mechanical circulatory support. Unfortunately, during the initial post-operative day, despite the escalations in dosage of 2 vasopressor and 2 inotropes, the patient still experienced a gradual decline in blood pressure, and her hemodynamic status was gradually deteriorated. And also, additionally, the ventricular tachycardia was consistently observed on the monitor. All the lab tests showed that the patient developed the profound metabolic acidosis with increased blood lactate and come along with the surge in troponin T from 4 to 5 and then persisting at more than 10,000. And similar trends were observed in the CKMB, creatinine, and BNB level. So we came up with the diagnosis of the severe metabolic acidosis with increased serum lactate, the cardiogenic shock secondary to the very high-risk end-STEMI, and the indications for the coronary angiography and revascularizations were recommended for these patients. And via femoral approach, we can see that the LAD, the RCAs, but also the bypass to those arteries are not significant stenosis. There you go. However, the image on this view suggests that there was a dissection from the left main to the circumflex, leading to the severe stenosis. So we decided to use two wires to cross to the distal of the LAD and the circumflex, and subsequently IVUS were utilized to assess the lesions. So the finding indicate that the absence of the dissection in the LAD. However, examination of the left main and the circumflex showed that there was totally separations of the intima and the media from the adventitia, together with the presence of the intramural hematoma. So the initial dissection site extended approximately 17 millimeters from the ostium of the left main to the ostium of the circumflex, with the smallest true lumens area was measured at the 5.84 square millimeters and leading to the 80% stenosis compared to the vessel area. We also measured the dissection angle at this site, and it reached approximately 230 degrees. So we decided to use a 4x 24 millimeter stent to deploy from the left main to the circumflex, and following by the post-dilation in the left main stent segment using the 5x 15 millimeters NC balloon. And after that, a cyan blue wire was rewired to the distal of the LAD, and then using the 3x 20 millimeters to redilate the ostium of the LAD, following by the kissing between the LAD and the circumflex. And after that, we used the 4x 20 millimeters to dilate the entire segment of the stent, and further post-dilation in the left main stent segment using the previous NC balloon 5x 15 millimeters was performed. And here is the final result. The coronary angiography confirmed the TIMI3 flow in the left main to the circumflex and the LAD. So the post-PCI IVUS, we also performed it, and the results show that there was no evidence of dissections at either both the proximal or distal end of the stent edges. Also, there was no evidence of the tissue relapse. In addition, IVUS verified the adequate stent opposition at both ends. We also measured the MSA of the proximal and the distal left main, the ostium of the circumflex, and the smallest MSAs in stent with the relative expansion approximately 94% compared to the distal reference. So all the results I will show on here. So after the PCI, the patient hemodynamic status and metabolic acidosis condition improved substantially, and all the vasal pressure drops were gradually tapered off and ceased entirely within 5 days. And during this period of time, the patient was successfully weaned off from the IIPP and mechanical ventilation. So the post-PCI lab test showed that the reductions in the troponin T, also the CKMB level, and improvement in the renal functions. And the patient was successfully discharged after 22 days after the PCI. So to sum it up, this is the 65-year-old female patient who developed cardiogenic shock following the acute MI after the valve replacement surgery, and was successfully managed by the PCI with the help of intravascular imaging. And we actually do some kind of review of literature, and here are our learning points. So first of all, iatrogenic left main dissections following the surgery is a rare entity. It has a wide range of clinical manifestations, from the accidentally finding via transesophageal echocardiography, like in knockout case report, to maybe it have the clinical context that present that resemble our cases where this complication was only recognized following the acute MI induced the hemodynamic instability, or maybe it could be fatal, like in Beria case report, where 3 patients unfortunately suffer from sudden cardiac arrest. The treatment options is a wide range. It could be the PCI, CBG, or maybe the conservative therapy. So from my perspective, I think it should be based on the timing of the diagnosis, the patient conditions, and the physician expertise. So in our case, the dissections was identified after the surgery, and it induced the hemodynamic instability and life-threatening arrhythmia. So PCI was safe, effective, and helped to reduce the necessity for further cardiac surgery. So that's a wrap-up of my presentation. Thanks for your listening.
Thank you so much, Dr. Zentinbell. Before I answer the question, so may I remind also panelists and presenter, we have just only 5 minutes for Q&A after presentation. So please, if you have any questions, Dr. Hui.
So thank you for sharing the case, and your team just have a good case. Yeah. So my question is there any CT scan or angiogram before the surgery? And then do you notice any problem with the angiogram before surgery? And if there is no, then how can we explain there is a dissection of left main just after the surgery?
Okay, thanks for your questions. Actually, I had to cut it off. There's a lot of information to shortening my presentations. Actually, the patient had performed a CT scan and before the surgery, and the result showed that there's no significant stenosis in the coronary artery system. About the etiology for the left main dissections, I reviewed the literature, the main etiology for the left main dissection following the cardiac surgery, it could be the dissections from the aortic root, and it propagates to the left coronary artery system, or maybe the direct infusions of cardioplegia solutions into the coronary artery, the solution to paralyze the heart, or maybe the intraoperative maneuvers. So the majority of documented clinical cases, as I mentioned above, the precise mechanism, etiology remain uncertain. However, from my point of view, I think in our cases, that would be due to the mechanical injury, because the whole process of extracting mechanical aortic valve was quite challenging, because the mechanical aortic valve has already been there for 20 years. And it was supported by the fact that the patient immediately developed hemodynamic instability and life-threatening arrhythmia when we release of the aortic clamp. When the blood come back to the aorta, it indicates that it's some kind of exacerbations of pre-existing dissections of the left coronary artery system. Yeah.
So I have a question regarding the sizings of the left main, because you measure it when it's already have a dissection. So would it be the oversize of the vessel or not? So what is your thought about that? And the second question is that anything at the osteo which is could be the stent deformity, because it's not a round one. So as you can see, it's the elliptical shape. So would it be possible that it's because of the guiding catheter, or you have any explanation why it's elliptical?
We choose the stent based on the IVUS. However, as you mentioned, the proximal of the stent is kind of shrink. And when we look it back to our case, the most possible explanation that would be due to the catheter engaged to the stent, because after the stent was deployed, the catheter was pushed back, and then we have to re-engage it, and it may cause the stent malformation at that proximal. Yeah.
My question is there any signs or symptom to suggest the patient has a problem with the left main before you do angio?
Actually, because the left main dissection is a complication that's more common when we're doing the PCI procedure. However, in the patient underwent the cardiac surgery, they are anesthetized. So the signs and the symptoms of ischemia, like the chest band, was hidden, totally hidden. So thanks for the closely monitor from the patient heart rate, but also the cardiac biomarkers after the surgery, we are fortunately identify early detections these complications. Yeah.
How about EKG?
Yeah, excuse me.
ECG? How about ECG?
On the EKG, it showed that the patient have the premature ventricular complex accompanied by the ventricular tachycardia was consistently on the monitor. So we decided to put the patient on the procedure. Yeah.
Thank you. Okay, thank you so much. If there are no questions, so may I invite the next presentation, Dr. Phung Chun Wu. Phung Chun Wu, yeah.
All right. So, good afternoon, colleagues and chairman. So, I'm Dr. Fong, a cardiologist from Hong Kong. So, today I will share a case of triple trouble to all of you. And I have no disclosure. And our case is a 70-year-old gentleman presented to us for chest pain for around 12 hours. So this is the ECG on the mission. So we can appreciate there is a significant ST elevation over the inferior leads. So, and we activate primary PCI for him. And this is the initial coronary angiogram. So the culprit is the mid-circumflex vessels. The right side coronary is not shown here, but it's just the recessive vessels. So there is also a very diffuse and calcified lesion over the whole LAD. So after some initial ballooning, there is a significant bifurcation lesion over the mid-circumflex and the OM2 vessels. So we'll put a 225 stent over to mid to distal third and OM2 with a standard OM2 with a 3O stent and with a bifurcation stenting. And this is the final result. We are quite happy with that. So the patient was then managed in CCU, and he developed cardiogenic shock with acute pulmonary edema. And the echocardiogram showed a very severely impaired left ventricular systolic function. The left LV ejection fraction is around 32% by Simpsons with global hypokinesia. The right ventricular systolic function was quite good, and this information is important for us to choose our mechanical cardiac support if necessary. And the valves are quite unremarkable. So the patient was stabilized with diuretics and with inotropic support. And then around 6 days later, we arranged impeller-assisted stage PCI for him. And this is the restudied coronary angiogram. And this is for the circumflex vessels. And we can appreciate that the vessel size of the circumflex actually grew much larger when compared to the index procedure. And this is the coronary angiogram for the LAD. It's a very calcified vessels, and again with a diffuse and tight lesion over the whole LAD. So we decided to do the PCI to the left circumflex first. So we wired both the left circumflex and the OM2, and we had done an OCT and confirmed there is a malapposition of the stent over the OM2. So we decided for optimization of the bifurcation stand first. So there is quite a challenge to deliver the balloon to the true circumflex. And we use anchor balloon technique with an anchor balloon inflated over the OM2. And we, after some manipulation, this is the anchor balloon over here. And after some manipulation, we do successfully deliver the plain balloon to the mid-circumflex. But after we deliver the circumflex, there's something missed here. The stand, the previous stand is gone. So this is a great surprise to us. And we go further distally, and we see actually the stand is migrated downwards. So it's possibly being pushed down by the balloon during the manipulation. So we change our strategy. We do an angioplasty first with a 2.5 and 3.0 balloon to the migrated stand to make it well approached to the vessels. And then we settle the bifurcation with a Coulomb standing with a 3.0 stand deployed at mid to distal third, and then with Hsic balloon inflation. So this is the final coronary angiogram with quite a satisfactory result. So we then move on to PCI for the to do the PCI for the LAD, and this is the OCT record for the LAD. So it's a very tight lesion over distal LAD. It's quite calcified. We can see more calcium here, and another tight lesion over the mid LAD, and all the way. This is another lesion over the proximal LAD, and it's actually a thin cap fibroathoma here. So the OCT show is a very challenging lesion. So these are our consideration at that time. The patient already had primary PCI done, and he's on dual antiplatelet therapy with a poor left ventricular ejection fraction. So CABG is, the risk of CABG is prohibitive for him. So in view of the thin cap fibroathoma, after it is well known that after standing of thin cap fibroathoma, there is a high risk of developing no refold phenomenon. The lesion was too tight, and the patient EF was very poor. So we can't just leave that alone and treat medically. And so third, there is a very diffuse calcified lesion over the mid to distal LAD, and we have to make sure that they are well settled to ensure good stand expansion and prepare for bell out. So we decided to settle the calcified lesion with rotational atherectomy, mainly done over the proximal to mid LAD with 1.5 burr for several runs. And then we further prepare the lesion with undersized NC balloon, a 2.5 balloon, to avoid creating low refold after dilating the thin cap fibroathoma. And then the mid LAD was stented with a 2.5 stent, and followed by another 3.5 stent over the proximal to mid LAD. So we then do a post-stent high pressure with a 4.0 NC balloon at the proximal LAD. Again, avoid touching the proximal LAD and the previous lipid-rich lesion. And another 3.5 NC balloon at the proximal to mid LAD, 3.0 and 2.5 balloon at the mid LAD. So after the post-stent high pressure, we check the coronary angiogram. So unfortunately, despite all the measures, and the patient still develop no refold. So we quickly give some a repeated dose of adenoscan with a Guy-Pass catheter and a Crusade microcatheter. And given the OCT findings, the most likely mechanism of the no refold would be the lipoembolization. So we also attempted a mechanical thrombectomy with a seven ventral thrombustor and the penumbra system. So this is the record of how we delivered the penumbra system, and to try to aspirate the lipid embolite, and try to help to improve the situation. So we also have to bear in mind there is other differential diagnosis for the no referral phenomenon. So we give a distal injection with a microcatheter, and we show that there is no dissection, and there is a very good backflow back to the mid-LED, and confirm there is no residual stenosis. So we then give more and more adeno scan. And finally, the coronary flow improved to a TB2 flow, and the hemodynamic is stabilized. So these are some discussion points for this case. So there is a very common, during the acute myocardial infarction in primary PCI, the patient may develop a coronary spasm because of the systemic stress. And so sizing of the stent may not be accurate at that point. And thin cap fibrosarcoma or lipid-rich plaque and represent a vulnerable lesion. And it's well known that after intervention, it may develop a no referral phenomenon because of the lipid emboli. So after stenting there are several differential diagnoses if a no referral phenomenon developed. For example, it can be an embolization, either due to plaque embolization, thrombus, or lipid embolization in our case. And it also can be due to thrombosis and stent dissection, coronary spasm, etc. So distal contrast injection with a microcatheter and intracoronary imaging is very helpful to help us differentiate the causes. And for the management of embolization, we can use vasodilator such as adenoscan, nicardipine, or even in desperate case, nitroprusside. And we usually develop it with a microcatheter or a guide extension catheter, or just somebody, and our expert panel just mentioned in a PSVA case, we can use a thrombustic catheter. So the idea is to develop the drug down to the capillary bed, which is the target of of our medication.
Báo cáo viên chỉ còn 2 phút trình bày.
Aspiration with thrombectomy system is also useful for lipid embolization. And some experts suggest a filter wire may be useful to prevent it from happening, but the effect is doubtful. And for thrombosis, we have to check ACT to ensure adequate anticoagulation, and we may consider giving a glycoprotein 2B3 inhibitor. So, ladies and gentlemen, these are the conclusion for this case. And preparing and anticipation of possible complication are very important for a successful CHIP PCI. And OCT gives us invaluable information about plaque composition and help us to guide our stenting. Mechanical cardiac support also allowed us for extra time for diagnosis and management should a complication occur. So last but not least, if complication occur, we have to stay calm but act fast. Thank you very much.
Thank you so much, Dr. Fu, for very nice case. So may I ask our panelists, have any question or comments? Yeah.
So may I ask a question regarding the rotor? So what is the speed that you use? Do you have any consideration about the high speed and low speed in this case?
Yes.
And the second is you have slow flow. So maybe Dr. Hui also have a question that do you think that the slow flow is happen because of rotor or because of the lipidic plaque, which is in the proximal LED, which is a really big chunk of lipid?
Yeah, thank you for your question. So we usually, for the rotor patient, for the first few shifts, we usually do 18,000 rem per minute. So depends on situation, we may use the lower speed for a polishing run. So, but the polishing one is not done in this case. So the speed is relevant because it may affect the particle you create and the risk of the subsequent node refold. So for the second question, For this case, because we are aware of the finger fibroma, so when we do the rotabation, we avoid the area of the finger fibroma. We didn't do the rotabation over there. We mainly settle the do the rotabation over the mid to over the post more over near the mid LAD, because the calcification is mainly over there.
So my question is in case we don't have OTC, so we get no reflow or slow reflow. Do you recommend to aspirate automatically for every case?
I think thank you for your question. I think it's really depending on the mechanism of no refill. So just as mentioned, there is other differential diagnosis, maybe a spasm or dissection. So for those causes, probably aspiration may not be very useful. So I think intracoronary imaging and also the distal contrast injection with a microcatheter is very useful for us to differentiate the cause of it.
Thank you.
Maybe I just add some comment, but not a question. Just by experience, we see that with cord, with lipid, always have, if you stand, always have no refill. Not always, but many of the time you have no refill. But some situation you cannot avoid standing, or you must do something. Some situation, then you do something, you will have no refill occur. In our experience, we found that if the no refill is occurred due to fungus, it's easier to manage. Most of the time, you just buy drug is okay. However, if the no refill is due to lipid, many of the time is not responsive to drug and is quite refractory. And because the lipid can fall in the coronary. In this sort of situation, we found that fungus aspirations can improve the whole situation dramatically. But if you don't do intravascular imaging, you cannot differentiate.
Okay, thank you.
Yeah, thank you for your presentation.
Okay. Thank you. So next, I would like to invite Dr. Phạm Hùng Cường. Yeah. Phạm Hùng Cường, or maybe the delay, yeah, flight delay. So I will ask Dr. Phạm Nhật Minh. Phạm Hùng Cường, yeah. Okay, thank you, because some changing for the presentation. Yeah. Dr. Phạm Nhật Minh, please.
So, Professor Chairman, the jury board, and ladies and gentlemen, so I am very sorry for my late presentation today due to the delay of my flight. So actually, we really have some incidents and also the accidents in your life, and today I'm going to tell you one of the most frightening moments or frightening cases of my career and my life. So actually, this the patient is just a normal case. She was a 77 years old lady, history of hypertension, and she's currently on perindopril and amlodipine. She has a rheumatoid arthritis, and she have on some kind of Medron medication and also the HCQ, and she admitted to the hospital due to the unstable angina, and otherwise she has no other sign of congestive heart failure or kidney failure, or the LVEF is still normal, and the cardiac troponin is also normal in this case. And from the right side, you also appreciate that the ECG looks quite normal. And actually, this case we did at about 6:30 p.m., the last case of the day. And actually, on that day, I have to be quite rushed because It was the birthday ceremony of my sisters. So what would you do when you have a rushing case? You have to ask your colleague, you have to ask your technician to do the case very, very fast. You have to be very, very rushing. And one important thing that you would like to do the very complex cases on the day you are rushing. So here's the CAG of the patient, and I think that we can appreciate that the patient has quite a tight lesion on the LAD. The proximal, the first segment of the LAD, and the circ is normal. And then here's the other view showing that the patient has quite tight lesion of the LAD. And the RCA also has a very tight lesion and unstable plaque. But with this case, we decided to do the LAD first, and then we would do the RCA in another time or the second stage. So actually, you really got what you wanted, quite a straightaway case. You can see that it is quite an easy looking LAD lesion that you can fix quite easy, and you can do other things else. So I proceeded to pre-dilate with the 2.5 compliant balloon of the LAD. And afterward, it was such a normal case. We put the stent, so we tried to put a 275 by 33 of the stent. But then from here, the problem began to happen. So firstly, the stent could not pass to the lesion. So what should we do when we have a stent when it could not pass? We use a parallel wires, and we use a bigger balloon to open up the lesion before you put the stent, right? But due to some reason at that time in my cath lab, we do not have enough devices, so that the only one balloon that the technician could give me was a 25 by 15 NC balloon. It looks a little bit too big, actually, but I decided to proceed with the case right away. And this is after this is how we ballooning the lesions with the 325 by 15 balloon. And then from here, the things happen, as you can see. I have never seen a case that the hemodynamic collapsed as fast as this case. In just 30 seconds, the blood pressure down from 140 or something to just 0. And as we can see, so I really realized what happened in this case. We may have some kind of coronary perforation. So actually, I did quite a quickest or the fastest pericardiocentesis in my life. In just 1 minute, we tried to put the catheter in the pericardium of the patient, and we start to drain, and then afterward, the hemodynamic quite come back. So what should we do at this time? An easy case could become one of the worst catastrophes of your life, as you can see. And actually, we called the cardiac surgeon, but he was quite busy because, it was evening, and we cannot. He is a cardiac surgeon on site. He only can be in 2 hours, and then we can have one of the most catastrophic cases of your life. So let's take a look at what really happened. So as we can see, it is a quite huge coronary perforation. And actually, we did quite fast. We do the pericardiocentesis. We do the prolonged balloon. And this is the same balloon as we do the pre-dilatation. And I was really stunning. I was really beside myself at that time. But then we have to calm down because we have to find a solution for the case. And all we know about the theory is that with this kind of perforation, firstly, we have to do the balloon in prolonged balloon inflation. And if the hemodynamic is unstable, actually, we really need to do something like cover stent, or we need to ask the surgeon to fix the perforation for you, which we cannot fix by the PCI. And in this case, the double guiding catheter is a very good technique and very good strategy to do, because we can have more spaces to add on and to put in the devices, and including the cover stent. And sometimes we will need the extension guiding catheter to make it easier to put the cover stent and other device into the perforation to seal that. But always, the old man said, easier said than done. It is very challenging to put in the other device through the second guiding catheter. And we see that with the prolonged inflation of the short balloon, it is really, the hemodynamic is really quite unstable. So we decided to inflate the old stent. We just throw away the stent, and then we use the stent balloon to have a longer prolonged stent of the balloon inflation. So actually, after the stent balloon inflated, prolonged, the hemodynamic become quite stable. And we can see that we can really appreciate that anytime we deflate the balloon, the hemodynamic collapse quite quickly. And after about 1 hour and a half, we have really of 500 milliliters of blood drainage. And actually, at this time, the cardiac surgeon is ready and the OR is ready also. But we don't have any chance to still in this kind of perforation. So we really tried and really take a chance to use a cover stent via the second guiding catheter, and we use a 3/24 cover stent as last resort for the case. And then we hope, really hopefully that the cover stent can cover the perforation. And actually I was really need to take the deep breath at that time, but actually the cover stent seals the perforations. And then the case was quite straight away afterward. We put in another Science Sierra stent at the proximal part of the cover stent and to cover the proximal lesion of the LAD. And then we do the post-dilatation. And this is the final pictures of the case. So this patient is still doing well after 6 months, and he has been seen by me in the clinic, but we have not done any follow-up strategy so far. So firstly, we can see that coronary PCI complication can occur at any time, and sometimes with this case, really iatrogenic, so it is really by yourself, so you need to care and aware about that. And sometimes when we should prepare for any situation, and it's better to do PCI when we are well prepared and we are well equipped with a good device and good balloon, for example. And you should never be underestimate any lesions and never do a PCI at any critical moment of your life. And also, the last thing is that you always need help from your colleagues. So in this case, my colleagues, my assistant, my technician, they are also act very fast. And actually, I did go to my birthday, the ceremony of my sister on that day, and I was really happy since I saved a life from my hand. Thank you for your attention.
Thank you, Dr. Minh. So may I ask question from panelists?
Yeah, so congratulations. Yes.
Thank you.
You saved the patient at least, I think. Okay. So what do you think is cause of perforations? Is it your balloon is too big, or because of heavy calcify of the lesions?
Yeah. Firstly, it's due to very big pre-dilated balloon, because actually I ordered only 275 balloon to pre-dilate the case, to pre-dilate the lesion, but due to some reason, this the only balloon that we have at that time it was a 3/25 NC and reused balloon. One important thing is that, and another thing that we really underestimated that reason at that time, because I was very rushing, and then I think that there's some kind of calcify at the middle part of the LD, so that is another reason for the perforation.
I think so. We may have some more comments in this case. So, add some lesson from Dr. Minh. But I think another important thing is you have to thinking about what you have available in your hand. In this case, the doctor try to inflate a very short balloon because at that time they don't have a longer balloon. So after a few minutes and after a few time to thinking about that, so sometimes we can use stand balloon. We can throw the stand away and we can use a longer balloon. So we can use that to see the rupture, and at that time we may have a time to prepare for the next step. Otherwise, even when you put a very short stand in this situation, the blood still bleed over the pericardial. Yeah. It is my.
So one another critical point of this case is that sometimes we think that we was really afraid that the cover stand may not enough to cover the whole perforation, because you know the cover stand only can seal the very small hole, but we really afraid that with a very large and big tear of the coronary, maybe it would not be enough to seal that. But we try in this case, and it's succeeded. But actually, we have another option is to send the patient to the OR and ask a cardiac surgeon to seal and to operate on this one. But luckily, we didn't have to do that.
Congratulations to you, but I have some opinion. The second why you use the ping pong technique. The second why you look wide to advance wide to the distal LD. I think after the patient have the perforate LD, the mixed LD, if you advance the loop with the second why, it make the more dissection and make the big perforate again. In my opinion, you avoid it.
I was very confident at my technique, and I think it is quite critical because we only have about 20 seconds or 10 seconds to do so, because actually anytime you deflate the balloon and then the hemodynamic collapse quite quickly. So I actually at any step you can see that, but we do that very, very fast too.
Okay, thank you so much. So,
thank you, Mr. Chairman.
I would like to invite the last speaker, Dr. Phạm Hồng Cường.
Okay, good afternoon, everyone. Thank you for having me here to share my complication case. I'm Cường from Hanoi Heart Hospital, and now I'm going to present a case that came to our hospital a couple months ago. And she was a 71-year-old female patient. She had a history of hypertension, diabetes, and 2 stents in RCA 1 year ago. And she consulted due to a typical angina, which was CCS3, and her troponin serum and echo in the beginning was normal. And when we took the angio, there was severe stenosis in LAD and left circumflex, which was Medina 011. And the culprit vessel might be LAD with severe stenosis and very calcified lesion. And you can see some signs of calcified nodule in LAD. In the left circumflex, we can see here a CTO in the distal segment, and in the large RCA, stents seem to be fine. So Our plan was standing from the left main to LED with EBU 3.5 from right radial artery. And with this severe calcified lesion, we might need rotablation. And then we intend to put 2 wire in LED for cutting technique. That was the type of lesion we had many experience before. Right after we kick off the case, we made trouble to cross the lesion in LED with run-through wire. And during catheter manipulation, we made a big left main dissection. Sorry, I don't have real image here because we did not inject anymore. Back to the case, we could not put the wire through the lesion because the wire was always into the foramen. And the flow in the left coronary arteries began to compromise. And her hemodynamic became rapidly unstable. We immediately inject noradrenaline and inotrope to stabilize the patient. And we made the first challenges, the left main dissection. What would we do? In that situation, we had 3 plans. Basically, we called a surgical team for preparing an emergency K-bridge. But all of operation rooms were on air and only available in less than 1 hour. So our plan was to continue the procedure while waiting the surgeon with less penetrating guiding and try to wire into the true lumen, accounting that maybe we would need mechanical support like IBP. Surely we must not leave it, so let's do this. We chose GL4 with a guiding extension to approach the left main ostium. And after many attempts, the run-through hypercode was crossed the lesion, but we could not advance even the smallest balloon through the lesion. Here we used a 0.75 balloon, but failed. Fortunately, the flow has restored enough for us to think next step. And this is a second challenge, uncrossable lesion. In that situation, we did not think that rotablation with rota-Y could have, because it was filled with the smallest balloon. So we intended to make some more dissection with granuloplasty technique. We made this kind of problem before, and we got them done with this technique. This is the case of restenosis in RCA stent, and the Y was sharpened, and even the smallest balloon were also uncrossable. So we used granuloplasty technique, and then the lesion was more open, and the Y was free to advance. This is another case with severe stenosis and a sharp Y in RCA. We put a second Y and made rupture with a small balloon, and after that the Y can be advanced distally. So let's try this. We use 0.75 and 10 balloon to make intentional granuloplasty. However, it was still failed. Here you can see some hematomas outside the vessel. So we think more and more about K-bridge. However, the flow, it was still okay, and operating room was still on air. So we checked the echo bedside, and there was no pericardial effusion. So we decided to try one more time. Back to the previous algorithm, we might need to increase the support with EBU guiding and another polymer jacketed wire to reach for the distal part of LED. So we kept whole system in place and chose the second guiding with EBU 3.5 from femoral artery, and the wire was filter XDA. And after many attempts, we after many attempts, we could wire to the distal segment of LED, and we made sure that the tip of the wire was in the true lumen. But after many dilation with the small balloon 0 and 0.1 and 1.5 balloon, even with some more granuloplasty, we could advance the 2.5 balloon through the lesion. But it was still an undilatable lesion. And that was the third issue in our case. This is another chart flow adapted by Manoj Brilakis for undilatable lesion. Some people say that our case was suitable for enterectomy, but with many big dissections we have made, we were not sure about its efficacy. This is my previous case when rotablation was used for heavily calcified lesion with many dissections, but the lesion was still not expanded, and we had to use body wire with an NC balloon, and then we made it open fully. Back to our case, we think about cutting technique with body wire and granuloplasty, and kept in mind that we still had the last choice, K-bridge. Back to our case today, we use 1.5 balloon, inflate to high pressure and made it rupture. And then we use 2.5 and 3.0 NC balloon with prolonged inflation. And after more than 20 seconds of inflation, we made the lesion fully prepared. And I want to say that here, it's just 1 more second, but can make everything change. And to save time, I cut some image here to this slide, and you can see many dissection we made and some cracked calcium arc. Now everything became easier. We put 2 stands in element LEDs, just like we planned before. And this is the final result with compromised left circumflex because of dissection. But with the collateral from dominant RCA to distal left circumflex, we think that this result was acceptable. We do IVUS again to check the result, and the stand were fully expanded and well opposed. The patient was stable with symptom-free and discharged 3 days after. And take-home message. The left main dissection is a catastrophic complication in PCI, and the key is keeping the wire in Chulaman and distally. And the reasonable wire balloon combination, like cutting wire with NC balloon or granuloplasty, is sometimes a bailout option in case of uncrossable and undilatable lesion. And finally, surgical backup is crucial, not only in the worst situation, but also for us, like as a mainstay to continue the PCI. Thank you.
Thank you, Dr. Phạm Hùng Cường, and congratulations for the cases. So may I ask our panelists for the question and comments? Dr. Hui.
So thank you. So my question is, I believe that you, the first guiding from radio, you cannot cross the balloon because of you have no backup.
Yeah.
So then you change the femoral.
Yeah.
So when you have a good support from femoral approach,
yeah.
So why didn't you just stand the left main first? Because when you stand the left main, you fix the dissection of the left main, then the guiding can have a chance to go deeper. Then you have more support to do the procedure. Otherwise, you put the patients, you keep the dissection there, you keep the guiding, and then you try to fix the mid of LED. Do you think it's too risky?
Thank you for your question. Actually, with the big dissection in left main, is the high risk with the patient. But when our wire through the lesion and reach the distal part of LED, the flow in the LED was good. It's okay, and the patient was still stable in the bed, and we decide to prepare more to optimize the standing.
A good case. After you success cases with many technique and many equipment, so you lost circumflex.
Yeah.
And it had a good collateral from the RCA.
Yeah.
And lucky for patient. But I think after you use the Gota ablation, I think, do you have a scoring balloon or not?
Yeah, we also have scoring balloon, cutting balloon in my CAD lab. But why didn't you the scoring balloon for this case after a rotator? A scoring balloon is the good choice, But we have many experience with NC balloon and cutting wire technique, so we could use both of the choice. Scoring balloon okay, NC balloon will still okay.
But in my opinion, this situation you use the scoring balloon because the patient have a severe calcium in the proximal RCA. And I was imaging so us you not good repair the lesion before you deploy the stent.
Why is not
the calcium not the proper after NC balloon?
Here, this is IVERS after we prepare the lesion, and you can see the calcium act was cracked. And so it is evident that we can stand very well here. The lesion was fully prepared with NC balloon and wire.
So the image in this left lower is in the false lumen, I believe.
Yeah.
Do you so at that time, do you think better, would you try to wire into the true lumen, or you because you stand that, so but at that moment, have you think about the double lumen catheter to wire to the true lumen?
Actually, in our case, I'm sure that in the ostium labment, where we were in true lumen, and the distal part of the LAD, we were in true lumen. Because in the middle LAD and the distal labment, we make big dissection and many dissection here, and we make some connection between true lumen and false lumen, and so we the false lumen or true lumen standing in our situation is not important more.
Thank you. Okay, thank you so much, Dr. Honker. Yeah. So I think we finished the second session with a very exciting session of the HSIC awards. So you all know the complication is inevitable in cath lab, so we can learning by sharing. So I myself and I think all of our panelists here really appreciate the information that all our young community of the interventional cardiology to share to us today. So I would like to close this session, and we may have 5 minutes to further next session. Thank you so much.
Ladies and gentlemen, as I have already mentioned, we have gathered some of the most brilliant minds in the field to share their insights, their experiences, and groundbreaking work on how to manage complicated PCI cases. We believe it could be an excellent opportunity for interventionists to learn from each other. Welcome to the My Worst PCI Complications and Unforgettable Challenging PCI Cases. Before we begin, I'm pleased to introduce our chairmen and panelists for our last section. First, I would like to introduce the chairman of our section, Professor Dr. Phạm Mạnh Hùng, President of the Vietnam Society of Interventional Cardiology, Head of Vietnam National Heart Institute. Next, I would like to introduce our co-chairman, Associate Professor Dr. Hồ Thượng Dũng, Vice Director of Thống Nhất Hospital. And also I would like to introduce other important panelists. Please welcome Dr. Simon Low from Malaysia. Dr. Lam Ho from Chuyên Môn Hospital, Hong Kong. And last but not least, Dr. Ngô Minh Hùng, Vice Head of Interventional Cardiology Department, Chợ Rẫy Hospital. Right. To begin of this session, please welcome Dr. Sozo Ishihara from Mimihara General Hospital to the stage and present the clinical cases. Please welcome.
Thank you for kind introduction. So I will talk about the very severe complication about during the CTO PCI. So I'm Shozo Ishihara from Japan, and so our hospital is in Osaka, and our hospital is very near from the Kansai Airport. As you know, Kansai Airport, we have direct flight from Hanoi or from Ho Chi Minh, so that maybe you can easily visit our hospital. Yes. So, as you know, when we do the CTO PCI, so we sometimes consider about the retrograde approach. This is a global algorithm of CTO, and it's okay. Yes. Now, can you see? Yes. So we can see we can consider retrograde approach like this, and this is one case of retrograde approach doing so from collateral channel across the wire, and also like reverse cut of something procedure. And there are so many collateral channels, as you know, and septal channel is relatively safe. But epicardial channels, if we perforate, it's a very serious situation. And so complication during retrograde CTO PCI is a life-threatening complication. And also donor artery trouble, for example, RCA CTO, but left main or LAD problem, trouble, and or epicardial channel perforation induced fatal problem. So that we cannot experience many trouble cases. I don't have so many perforation cases, but so it is important to learn from others. So I will introduce one case. The patient was 66 years old male and stable angina, and he had an LAD CTO lesion, and we can see the collateral from RCA and from circumflex. And it showed quite viability in LAD lesion, and also ejection fraction is a little bit reduced. And for the viability, we decided to perform CTO PCI. But this case is not in our hospital, but other hospital. And so the young doctors who want to do CTO and want to learn CTO, so that I visit the hospital in Japan, and also I teach. And so young doctor try to do by himself for this CTO lesion. So this is a LED CTO like this. And also we can see the good collateral from RCA like this. This is a CTO distal part. This is a very good collateral channel, but unfortunately there is a strong bending point here. So we start PCI, double guiding system, antegrade 8 French and retrograde 7 French. And we discussed with local young doctor. And so he chose retrograde approach first. And first channel, he want to try RCA. And next step is circumflex. And third is septal surfing, because septal channel is unclear. So he start from RCA retrograde approach like this. We can see the good connection. And the vessel size is relatively enough big to cross the wire and also microcatheter. And so using Caravel microcatheter, and he tried to cross this bending part using SO03, very soft wire, and also Caravel microcatheter. But we can see microcatheter is moving like this with the patient heart beating like this. And the wire is coming here. In this point, so let's check contrast injection. I say, unfortunately, very severe perforation like this. And this is a collateral channel, so that blood flow is coming antegrade and retrograde. This is antegrade, retrograde, yeah, but so both bilateral side. So it's a problem. So at first, we quickly open up the balloon as the proximal part to stop bleeding with using 2O balloon. And so opposite side, we check. So we can see a little bit still bleeding, but I think it's acceptable. So that at this timing, change the operator from the young doctor and to me. And also, we gave up using this RCA channel. And so I start to retrograde from circumflex channel like this. And fortunately, the SO03 guide wire crossed the very tiny and bended channel like this. And the wire reached to the distal LED. Okay, I will show later. So this is a microcatheter, and also this is a wire. So fortunately, microcatheter reached to the CTO distal like this. And so we can see both so bilateral injection. After that, I advance the wire from retrograde, ultimate velocity, XTA, and next gladius. And so after that, I advance antegrade Gaia next to with the information of retrograde wire. So finally, I checked IVAS and also perform the reverse cut with using 2O balloon. So after that, retrograde wire can cross the CTO region, but unfortunately, the retrograde channel is too much long, so that a Caravel catheter cannot reach to the antegrade guiding. So that I advance one more guiding, so that RCA guiding, LCA guiding, and additional guiding. And so I advance the guide extension catheter, guide plus. So retrograde wire and microcatheter can insert into the third guiding catheter. Yes. And so we perform the externalization. And in this point, we check the bleeding. So after deflation, but still bleeding, still continue bleeding. Yes, so that, and after that, after deflates the balloon and checks the contrast, but so in this timing, so blood pressure drop down, and we should do pericardial synthesis and drainage. And after drainage, patient was stable, so that continue to perform the LED PCI. So after wire crossing, it's easy. 2O balloon dilation, 3O balloon, and non-compliant balloon dilation. And also put stent mid LED, and also after that, I want to check the bleeding, because if I put whole stent and I get the enough coronary flow of LED, maybe coronary perforation site will bleed more and more. So that I check, but still bleeding. So that antegrade, fortunately, I can cross the CTO region, so that I advance the microcatheter like this, and so put the coil here from LED side, like this. This is a one coil. The company is Cook, and so this is the second coil. But after putting coil, so antegrade or maybe bleeding is stopped, so that I start retrograde. So I put one more stent. After putting stent, but still bleeding like this. So in this point, I put the stent from RCA side like this. So bilateral coiling was performed like this. And check once again from RCA side, but still bleeding. We can compare. Still contrast is staining. So that in this point, I changed my mind. Not only coil, but I put the thrombus from the microcatheter. So we can get the thrombus easily from the puncture needle like this. So we get the thrombus, and so from the microcatheter I put, and so fortunately from RCA side we get the enough hemostasis, bleeding stop, and also LED side we check again with microcatheter, but unfortunately still bleeding. What we can do? Almost already thrombus was used, so that I get the fat tissue from the patient. We can cut the femoral puncture site and using like this small cutter, and I injected the small fat tissue at this point from microcatheter. So LED side also stop bleeding. And this side RCA, this side LED, CTO was opened, and also hemostasis was achieved. So this is the final result. It's an acceptable result. This is a case summary, 66 years old male, but procedure time is 6 hours. Very long time, starting from young doctors and change to me. And so stop bleeding is so much long time, yes. And so to stop hemostasis, to stop bleeding of channel perforation, we should detect the bleeding side. And also sometimes microcatheter wedge and also negative pressure is one option. And another one is, as I did, prolonged balloon inflation. Long time balloon inflation also important. And if we need, we do pericardial centesis. And also another option is embolization. We should know coil, thrombus, and fat tissue or something, so that we should prepare this kind of embolization technique. And bilateral embolization, front side and also back side should be considered when we face to the channel perforation. So this is a coil, so that we should just prepare just in case. So this is the last slide. Complication happens suddenly, and we should prepare bailout techniques and various options. And bilateral side hemostasis should be considered for severe perforation, and get used to various embolization. Thank you for your attention.
Thank you so much, Dr. Shozo Ishihara, for very interesting case. So may I ask our panelists, audience, have any comments or questions?
Thank you very much for your very exciting presentation, I think so. Actually, I also learned a lot from you because I am also do the retrograde, but they very rarely use the epicardial collateral. So I just had a question for you that in this situation, when you first fell with the cross the epicard, so do you think that you will continue failing that you use the second? Because they already fell. So you use the circumflex to go to the distal LED, and then if that still ruptures, so how? So how to solve the problem? And in order to maintain the procedure quite long, about 6 hours.
Yeah.
So how to keep the ACT in order to maintain that still good coagulation and balancing between that and continuing doing the procedure? That's the key. I think the key point in this situation. Thank you.
Yes, it's a very important point. And so after perforation, we should consider about the ACT. Of course, no perforation, we keep the ACT around 300 something during the CTO-PCI, especially retrograde approach. It's very important. But this kind of severe perforation, and we need pericardial drainage at that time. So it's very difficult. So in this time, so we keep the ACT around 200, around 200. And yes, it's one point. And also, so change from young doctor to for me. So I can't say I'm expert, I don't know, but so maybe I have enough experience for retrograde. So to help the patient at that time, maybe, of course, young doctor is difficult to do this kind of procedure. So that we changed, but it depends on the situation. So young doctor also need the experience, but so rescue is more important. So.
Yeah, I think a very difficult case. Because when we do a rupture or bleeding from collateral vessel, it bleeding not only one way, it's a two-way. Yeah. From the donor vessel and from receiver vessel. So in this case, I think very, very, very difficult, very complicated case. You have the long way to occlude the bleeding. You use the coil, you use the prolonged balloon inflation in combination with the coil, with thrombus, the embolism with the fat tissue. So I think I'm not experienced about the CTO-PCI, but I think the better way to avoid complications. Yeah.
I just add one more comment. On top of fat cord, nowadays I like to use wire cord. Just the absorbable wire, the suture wire. You cut it into pieces and then can push it through the microcavity. And then the wire cord can seal the perforation. Sometimes,
So as a coil, you use a wire, cut wire?
Absorbable suture wire. The wire cord. The wire that you use to do pacemaker or to do the suture. The suture wire.
Yeah.
And then you cut into small pieces and then you can fit it in.
I've never done, but it's a very nice option. Okay.
Yeah, interesting cases. But in my experience, sometimes we also use another tip to use the tip of the balloon. We cut the tip of the balloon and we push to block the perforations.
Wow.
Have you ever used that?
I have no experience of that. So okay, so maybe if it is a very distal, and so of course it may be one option. Oh, thank you.
Yeah, no more. For such a big channel, probably coil is still the best. Yeah.
Okay, thank you so much, Dr. Soyo.
Thank you so much.
Excellent presentation.
The next speaker, we would like to invite Associate Professor Panipa Sunwanasom, present the case second, case 2.
Okay, sorry. Thank you, Mr. Chairman, for your introduction. So actually, I do not complication much because I don't do the complex one. I'm too lazy. But let's see that I hope that will be something that interesting. So this is a man, 50 years old, so referred from the primary hospital because of non-SEMI. And really he spent his life in alcohol drinking and also the history of amphetamine use. So, as you can see from the echo that this patient has like EF just only 15% with the spontaneous echo contrast with the poor of RV and LV function for this case. And for the valve, it's just like my MRTR. So at the beginning, because the patient came with the non-SEMI, okay, we take the patient for the coronary angiogram. So as you can see from the bifurcation of the, actually it's a trifurcation of the left main, as you can see this also here, with the shunt of the calcium. And in other view, so as you can see that we barely see the ostium of the LAD, of the left circumflex, and also the ostium of the intermediate, which is like have many view, and we cannot figure out that is there any disease in such ostium or not. So for the right coronary, it's quite okay, so it's only a mild disease. Of course, because the patient got poor LV function, so we have to send the patient for the heart team meeting according to the national policy. If we are going to do the revascularization of the patient like that, we must have the document of the heart team meeting. So the surgeons say that, are you sure that the patient got the EF15 because the left main is that possible? The patient, the main problem is the alcohol. I say, yeah, I also think so because the patient is a heavy alcohol drinking, but do you dare to let the lesion with the 80% of the left main there? Okay, so the surgeons say, okay, so shall we do like this? We do the MRI and then we'll see that again. And they say that if there's just only a small area of ischemia, so we can do the medication or you just do the PCI with the stent across, fine. Okay, we send the patient for the CMI. As you can see, the LV function is poor, RV is poor. And the funny thing is that no evidence of relevant hypoperfusion, and the delay enhancement is negative for the late gadolinium enhancement. So, do you want to do anything with this patient? Stay with the medication, or you think that with the left main with 80% and this has to be fixed? So we bring the patient back for the heart team meeting number 2. So the heart team say that, okay, of course, we are not happy to let the patient live with this lesion as well. So maybe we just do like one stent, provisional, done. Yeah. So the plan for the procedure is like, okay, it's a trifurcation, but it's really difficult to figure out how many of the vessel have been involved. And because as you can see that we have a big chunk of calcium, okay, we'll stand by for the rotational atherectomy. And this is a really angulate LD takeoff. We plan to do this with just only provisional. Don't want to have any complex procedure because his EF is just only 15. Of course, it's going to imaging guide and hemodynamic because we don't have impeller in Thailand, so you have only ECMO or IABP. So the surgeons say that, okay, no problem, my sister, so I will have a VA ECMO standby for you. So if you need any help, just scream it. Okay, so let's see from for the pre-procedure. So as you can see, so there's a lot of color here, but as you can see that we have just like the shot of calcified lesion here, and this is the opening of the intermediate, which is an angle is quite like not the normal one, so it's quite tortuous. And as you can see that the ulcer that you see from the angiogram, So that's also content of the attenuated plaque. So as you can see, everything is in the darkness. So it's not calcium, but it's just attenuated plaque. So talking about the calcium, of course, we have this just only if we have to think about whether we need a rotational atherectomy or not. Of course, this patient is just only one. So maybe we can manage with the cutting balloon. So as you can see here, so we use an NSE followed by the NCU fora, and then with the biometric, just only at the mid part. And then with the, actually for the NSE is prepared from the mid LAD up to the left main. And then this one has been re-dilated with the NC Acufos and the less load integrity 4.0. So as you can see here, so the flow is quite okay, not bad. And then we do the part with the NCU for our 5.0. And now we got a problem. So as you can see, before we do the port, the flow to the intermediate is quite okay. But after the port, where is my flow? And actually, as you can remember, that this intermediate is a really big branch. So the patient now develops chest pain. Hemodynamic stable because we already put the IAP up front. So at the beginning, it's like we try with the Y with the double lumen catheter with the Hsic, but it cannot entry to the intermediate. So nitro, pot, anything I give. So with the double lumen catheter cannot pass to the opening of the intermediate. So what should I do? Because I'm not sure whether what happened, so I decided to do the pullback from the LAD to understand that what was happening at that time. So as you can see here, so actually the stent in the LAD is still not in the good expansion. So I think that, okay, I will do the post-dilation after I fix the problem with this intermediate. But as you can see that the intermediate, previously you see the very beautiful of the intermediate opening, but now I just see it like this. And then, as you can see, there's a discontinuation of the media around here. I'm not sure whether the problem that happened is because of hematoma, or is there anything that happened to intermediate because I do the port, or because I use an NSE to prepare the lesion, and then followed by port. So everything just like have a concealed perforation or not. So, and this is opening of the left circumflex, still okay. And as you can see here, that's the major malposition at the left main strut. Okay, so the problem is now I do everything. I already used the double lumen catheter. I cannot wire. So at that time, I just thinking that, okay, we go back to the previous slide, and you see that actually it's good. I'm not sure whether to say good or not, but because we have a malposition here. So I think that even if I have to do some deformation of the left main stent, maybe I have to do that to create the way to go into the true lumen. So be it. So finally, I use the small balloon. So go under of the left main strut and then dilate it. Okay, I can go with some advance of the balloon there. And as you can see, the flow is quite more or less become better. So I get another wire and try to wire in to follow so this is in the 2 lumen with the Hsic catheter, and try to follow the part of the previous one. Yeah, but as you can see, even I go there, the IVUS catheter cannot go, so the wire just can't go. So I decide to use a balloon, the small balloon again with a sapphire balloon. Oh, I already, so the time out, 0? Oh, sorry, time out. Okay, but anyway, so we go on. So IVUS is now entry to the intermediate branch. So I do the marking and checking whether I'm in a true lumen or not. So as you can see here, that of course I already used the balloon to distort the left main stent. So as you can see that this is the stent that I already distort from the round one, and then I have the wire here, and then Now you see the cause of the problem. The problem is because we have hematoma here. This volumen is true lumen, and it is a dissection of the ostial of the left main, which I consider that maybe happened during I did the NSC for the lesion preparation. So, so what I did is I used the NC to just open, because now I'm sure that I'm in the true lumen, right? So I use the NC to open the strut, and then I implant the stent. So this is not sure whether what to say, but it's going to be, I think, not sure whether I can say that it's a tap or not, because actually the angle is really not a tap at all. And then I do the kissing, and then do the kissing and port, and then I check again. So as you can see here, so this is the left main down to the mid LAD. So now you see that the strut like protrude in the left main, and this is the intermediate strut. So at the LAD, still I noticed that I have this under expansion, so I have to do the postulation in the mid LAD again. So now we go to the check of the intermediate. So the intermediate, as you can see, because the kissing has been done with the NC40 and with the stent. And as you can see with the stent, you cannot have the force enough to open the strut well. So as you can see, so if you stop without seeing this and think that you already do the kissing, this will be catastrophic, right? Because it's under expansion of the ostial intermediate stent. So finally, what I have to do is I do the kissing again with the NC both, and then do the imaging. So as you can see now, the opening is now become better. The intermediate opening is good. And so I think just only for this case, what I regret is, is that I still cannot fix the problem with this malapposition at the left main, because the vessel size is too big. So it's like 6-0, that we do not have a balloon to bigger like that, and especially the stent that we implant is just 4-0. I think no any stent in this world that can go to the 6-0 for the time being. So in this patient, because the strut is like floating in the left main, so I think that the patient should be in an extended depth, at least, if allowed, that will be about 24 months. So the echo was done in the 6 months later, and the EF improved from 15% to 40%. And the medication that patient got is just ACI, spironolactone, beta blocker. That's it. So actually no fancy drug, no SGLT2, because it's the problem of the reimbursement. Yeah, but still we can see that the spontaneous echo contrast. He stopped smoking, stopped to use illicit drug, and also stopped drinking. So in this case, so as you can see that, of course, we have a dissection of the intermediate. You can notice that you use imaging to guide where is the correct way to go. Of course, if you cannot go with like conventional way, so maybe have to destroy your left main stent. But of course, you have to fix that later when you got the true lumen. And so as you can see, I was helped to confirm. And of course, this one has to be really careful if you do the oversizing. Otherwise, if you have a fracture, maybe that will cause the more problem afterwards. So thank you so much for listening. Any question?
Thank you so much, Dr. Suwannasam, for very interesting case. So may I have a question to you? So if you had a chance to do again, so what would you may change your plan from the beginning? For example, you will protect the side brand with something like a crush technique or something like that.
Yeah. So actually, if I can turn back time, what I'm going to do is to check all the side branch, which of course, because I'm already wired, but it's just like at that time, I don't know, I was like maybe ghost in my body. That I don't think that I should check. But because you already wired and you already have an IWUS. So for me, if I can turn back time, I will do the IVUS, inspect all the branch, and then decide that again. Because I already know that I cannot see any osteo clearly. Yeah.
Thank you. Okay, thank you so much. So next speaker, I would like to invite Dr. Lam Ho for the third case.
Yes. Hi. Good evening, everyone. This is one of my most unforgettable complication case. Can we remove this one? Remove the timer. Yes. Okay. The patient's clinical history is very simple. A lady around 60 years old. She got very poor DM control. HbA1c was very high. She was admitted for ACS. ECG was non-specific. Echo good LV function. Troponin I was elevated. So we go to see the angiogram of the patient. This was the RSA. Nothing special. There's some lesion over the mid-RSA. Nothing special, right? Yeah. And then that's the left side angiogram. Do you see anything horrible? Can you see anything horrible? Of course, mid-AD, very tight ACS case. Anything horrible? Can you see anything horrible? I cannot see it, but there's one very horrible lesion over here. See it again. Can you see? No, nothing. Okay, another view. Can you see anything horrible? Is it just a usual ACS case with different view? Which part of the AD is the most terrible, most horrible? Which lesion is most horrible? Okay, nothing, right? So, as a usual practice, we just dilate and then do the IFAS from very distal AD to the left main. Okay, this was the angiogram of the AD, and then we do the IFAS. Did you see anything horrible in the IFAS? So we start the IFAS from very distal AD. You can see very small vessel, many of lots of lesion, lots of plaque. Plaque burden was very heavy, but nothing special. It's just as usual. We know the plaque burden is heavy, lots of plaque. You know, there's an aneurysm. So we shortly will go to see. Probably we are somewhere over here. And then it's manual pullback. And then here is the aneurysm. So here is the aneurysm part. So further pullback is to see the lesion over here, over the proximal AD. So let's see. Okay. Do you see anything horrible? Okay. This is the left main. Okay. Let's see again. So this is the aneurysm and then proximal AD part. Yeah, we also missed this, the fellow of course missed this. Can you see here? Actually, there's some fat. It's not OCT, it's IFAS, so you cannot see very clearly. Actually, there's a part rupture over here. And behind this lesion, let me show you again. Let me show you again. Can you see the fat? Can you see the part rupture? And then behind this lesion, why is so dark in color? It's not calcium. Calcium don't look like that. It's lipid, in fact. And it don't look like cord. It's actually lipid, very dark in color. In IFAS, in ultrasound, if it's calcium, it's bright in color, white. If it's very soft lipid, then it's very dark in color. So we see it again. So make sure everyone see it. So we can see here is the pulp rupture. So the most tight area may not be the culprit. The culprit is here, the proximal AD. And it's very dark and it's not calcium. So most likely it's lipid, very lipid rich. So just stand as usual, and then put one stand to the oxyl AD as usual. Nothing happened. And then see the time. I particularly show the time of the procedure. Can you see? It's 12. And then do the high pressure ballooning as usual. And then after that, 1 minute later, after the high pressure ballooning, while you do the high pressure on the lipid-rich part, you see, no flow in AD, no flow in circumflex, and the patient short. You can see the contrast stationary in aorta because BP drop. Why this will happen? Because it's a very lipid-rich part. You do the high pressure, and then it's not caught, it's the very soft oil lipid, and then the lipid go to distal, so AD no flow. You can imagine you squeeze your high pressure, and then the lipid go to the left main, and the blood continues flow from left main to AD, but your balloon was inflated, so it will push the lipid from left main to the circumflex. So both AD and circumflex no flow, just inflate. You see the time at once, no flow in AD and circumflex. Of course, my fellow give adrenaline, give adenosine, but no flow in AD insert arrest. Just a few minutes, no time to react, because the no refill by lipid is different from the no refill by cord, by air. It's different. Lipid is very oil, very sticky, and then it will block all the capillary. Most of the case need very long time to recover, and very difficult to manipulate. And most of the case, it will be refractory to your drug treatment. That's why sometimes you have no refill, you give drug treatment, but no effect. It's because most likely it's due to lipid-rich part and then induce no refill. So repeated adrenaline injection, everything. It seems okay. The patient's BP is stabilized a bit. You can see some movement. The flow in the circumflex was still slow. And then a few minutes later, of course, the patient still unstable, continue monitor and give drug to treat the no refill. Just a few minutes later, you can see the natural history of a lipid-rich part induced the no refill. Few minutes later, the blood is very poor, and you can see the circumflex flow still very slow. And then 1 minute later, despite all the treatment, seems you gain some flow, but it's gain some flow in the epicardial vessel, but the capillary are still full of oil. And 1 minute later, patient arrests again. What should you do now? What would you do? It's because in ECC I present one case, is no refill. We found that impeller is the last weapon and can help to treat the no refill. Because if you see arrest case, no refill case, you see the LV go like a ball, dilated, and the capillary pressure will be very high. If you put the impeller in, it suck the blood and then shrunken the LV, it can reduce the capillary pressure. At the same time, it produces a hemodynamic support, increase the pushing force, so that you can treat the no refill because you increase the pressure difference. So, but this is not evidence-based. In fact, impeller is very expensive. Do you dare to put it in while the patient on CPR, while push the heart? So after some discussion, we decided to do. And it's full recorded impeller instruction during CPR. We can show you, we can do it in 60 seconds. So You see the time, 12:30. After establish the vasa access, everything, and then they push the wire through the pigtail. Remember, use 5-inch pigtail. And then 6 seconds later, you can remove your pigtail. This is the impeller wire. But remember, continue to do the CPL. There's no hindrance for your CPL. You just do it, keep doing CPL. Make sure the patient don't have hypoxic brain. And then 60 seconds later, you can see. Continue to press the heart. Make sure the patient don't have hypoxic pain. When the impeller go into the aortic area, sometimes you will have some resistance, sometimes no. It's because the aortic valve will close while the patient's heart do not beat. So you just press the heart, open the aortic valve so that you can push the impeller in. So just 60 seconds, we put the impeller in. 60 seconds, 1 minute. And then start the impeller. Okay. And 10 minutes later, while the impeller keep function, keep the hemodynamic, and continue to give some drug, and the flow establish, the brush improve a bit. So the flow restored, and the patient was safe, no hypoxic brain. So you see the full record, 1 minute, we finished the impeller. And this is restudy angiogram 2 months later. Now everything okay. So you can see so terrible for the lipid-rich part induced the no refill. So let's see the horrible things again. So now I think you will gain something, and next time if you see the part like this in IFAS, you will be very, very careful. Hot part rupture, you can see the fat. And then behind the fat, this dark color things, soft lipid. It's a spectrum. Sometimes some lipid parts are not that horrible, but some are very liquid and very sticky and could be very horrible. But from angiogram, you really can see nothing terrible. You won't think here is the culprit. You may just stand from here to here. But in fact, the most terrible thing is over the proximal AD. And I can show you the ST, there's no acceleration, you just stand the distal part, it's not culprit, nothing happened. Stand the proximal AD, nothing happened. And only after the high pressure ballooning, on the proximal AD, start to have acceleration, ST elevation after the ballooning. And then quickly the patient arrests. So, ask you this question again. Now can you see anything horrible from the angiogram? And that is the take-home message. Impeller can be as the last weapon for no refill. Stenosis is not equal to the hot culprit lesion. The most narrow part may not be the culprit. Be careful, no refill caused by lipid-rich part is another animal. It's different from the story you see before. Okay.
Yes, thank you so much, Dr. Lam Ho, with a very interesting case. Long way to manage the patient, but with the last result, very excellent. So, if you redo again this case at the beginning, what you do to avoid this complication?
Yeah, I think is to...
And maybe between IVERT and OCT, if you use OCT, what do you think might be different?
For OCT, the first question. Actually, this complication can be avoided because you can just stand the proximal AD, you don't do the high pressure, give the patient statin, give PCSK9, and then we study few months later, and then do stand optimization. Then that can avoid this terrible complication. All this happens because you miss this lipid-rich part, and then you high pressure. and then it causes the problem. Or you look it down, you think it's a little thing, you just high pressure, and then it causes this problem. So how can identify is by angiogram. You can see that from this case is impossible. So only either by IFAS or OCT, both can be used to identify this situation. But for IFAS, you need more experience. Like this case, the fellow missed. For me, I read it again, I will also miss. Why I can see that is afterward. After the case, I reviewed the IFAS. I found that that is the problem. But for OCT, you can see the vulnerable part very clearly. That is 99% is IFAS better than OCT, but in this sort of situation, OCT can help you to visualize the vulnerable part more clearly than IFAS.
Dr. Lam, is it the hypothesis that the lipid pool is the hue at the proximal LED? Is it correct?
Yeah.
And the ulceration is just the hole that's when you go with a high pressure balloon as it squeeze the lipid out from there. To the distal end of the vessel and to the circumflex.
Well, there's a part, the balloon, high pressure balloon in phase. Of course, you squeeze some that
squeeze the
emboli down. Of course, and on another way, it will also squeeze something to the left main, to the proximal part. But proximal part continuous pressure from aorta, so it flush everything into the circumflex.
Yes, and in this situation, if you redo the procedure, so do we to stop that at that point of time, and then we use the high statin, low of statin, or 1 or 2 months later, and come back and we do the procedure? Is this safer?
Yeah, if we do the procedure, we'll give prophylactic adenosine first, and then just put VO stent and go. And then we study few months later, optimize few months later.
Yeah, thank you so much.
Thank you, Dr. Sojo.
Yes, thank you so much. So I agree with you. So at that moment, so of course we can treat distal part of LED, but so proximal part, after checking IVAS, there is a so huge lipid-rich plaque. At that time, don't touch there. Is the most important thing. And after stabilization with lipid-reducing treatment, after that we can touch. And also, maybe, of course, IVAS can give us the very good information. But so maybe everybody cannot use IVAS because of the price of something. So that CT angiography also give me a very good suggestion about lipid-rich plaque. So that is this patient already done CT angiography? No.
We can't in Hong Kong. CT angiogram is a luxury.
Yes, I understand. So first of all, so treat LED, and after that, then so of course high statin or PCSK9 or something, and later check CT angiography. Maybe it will give us more information, and also of course IVAS also important.
Yeah,
it's my comment. Thank you.
Very good suggestion. The important learning point is impeller can be used to treat no refill, even the patients are in RS. Yeah, and the second thing is to see the natural history of lipid, which part induced no refill. Yeah.
Okay, thank you so much, Dr. Lam Ho. And we would like to invite Dr. Simon Lee with the last case in this session. Lee? Simon Lee.
I feel very short here. I just make it. Thank you very much. When I landed in the airport, when it's about to land, and then the air stewardess make an announcement and said, ladies and gentlemen, we'll be landing in Phuket Airport. Yeah. Did it happen to you, Dr. Lam Ho? The air stewardess, the captain said, we'll be landing in Phuket Airport. And I thought, how come I'm landing in Thailand, Phuket Island? But Luckily, when I got down, it didn't look like Phuket Airport. It's a much smaller airport. And it's my first time here. Anyway, thank you to Dr. Ang, Dr. Hui, for inviting me here. And good to see the old friends. I'm the last one to talk. I don't know whether my slides can be connected. Does it work? Actually, I feel very short standing here. Oh, mine is not strong enough. Sorry to hold you back. This is the last case. Yeah, but I think after Dr. Lam Ho's case, sorry I didn't see anything of your case. I asked the driver to drive a bit faster, but the speed limit is 60 kilometers an hour from the airport. And I have to pay the fine or the summons. I told the driver, Dr. Ang can pay, but he refused to drive faster. Oh, I entered my password. Oh, goodness. Now I can see you better. Hang on, I have to go here. I am on this lecture mode. Oh, next one. Still cannot? You copy? Still cannot. There are only 2 pots. Copy? Yeah? Mm-hmm. Yeah. I will show you which folder. Can the panelists keep talking whilst I go and fix this problem? I think I have to download. Cannot use my own laptop.
Oh. I think why I did not make any comments on Ishikawa's case. In fact, it's very difficult to make better management than his management on the perforation. In fact, that's a very classical and very educational case. Try to remember this case because it could happen while you handle epicardial channel. While you're doing retrograde CTO epicardial channel, this is the most terrible situation. That is the things that I want to say, and always learn a lot from his case. And for the closure of the Ramus case, for bifurcation, sometimes really difficult to predict. There are 2 situations that will make things very unpredictable. One is calcium, one is fungus. I found that most of the time you can predict the bifurcation will close or not, or you can predict everything 99% correct. But if in the bifurcation you see fungus and calcium, these 2 things will make things very unpredictable. Sometimes even very simple case, simple lesion, it will also close. And that is my previous painful experience. So when I see calcium and fungus, my first hope to do more maneuver, including upfront 2 stand, is lower. My threshold to do more maneuver will be lower once I see calcium and fungus in bifurcation. Yeah.
So I have a question for Dr. Lam. Yes, I have a question for you. So what do you think, what we can do if we have another same situation that we have a very rich lipid lesions? We can see on the IVUS. Should we do like more heparin nice, or we do more strong antiplatelet therapy? What should we do to prevent that kind of complications?
I think not much thing can do. Even you use PCSK9 statin, all the study it just show that it reduce the length of the lesion, but it will not reduce the thickness of the lesion. Most of the case like this will not have problem, but once the lipid-rich part is large or the length is more than 13 mm, then the chance of no refill will be very high. Someone said you should use filter wire and then can prevent the no refill, but Japanese had done the study and they used filter wire. They found that not all the situation can prevent no refill, maybe just less than 50%. So don't think filter wire will work for this situation or drug. Do we still need to keep talking? And then is your PCI strategy. Always remember one step think forward, one step think backward. You have this experience, you know no refill can occur, then you need to think about the solution. Yeah.
Okay. Sorry to interrupt, sir. Sorry to keep you back. I hope this is the last case. And my name is Simon Low. I'm from Penang, Gleneagles Medical Center or Hospital. It is about the worst nightmare that you can get in your whole career as a cardiologist. So this is what it's all about. Doesn't matter how good you are in interventional cardiology, you will get complications if you do enough cases. And as we get along with our career, we become a bit more daring, you know. We take on more and more challenging cases. And this is such a case, okay? Now, what a day. It was pouring. It's blood. Okay? Very quickly, to summarize, this was a 75-year-old woman who weighed only 56 kilos, but she has 20-year history of diabetes and hyperlipidemia and hypertension, and angina in 2008, and the positive stress test, strongly positive, but still good LV function. In 2008, she had an angiogram that showed LAD 80% approximately, distally 90%. Circumflex also significant in the mid to distal circumflex 90%. And cipher stents then, my era started, and the cipher stent was implanted to the proximal LAD and distal LAD, as well as the circumflex. She remained well, and unfortunately or fortunately, she defaulted clinic, never turned up to clinics until November 2016. That's 8 years later, okay? Complaining of angina, and all her risk factors were not perfectly controlled. Again, stress tests become positive in stage 2. And she was advised to have an angiogram, November. That time I saw her. And this time it shows an osteo-LAD lesion, mid-circumflex, same 80%, before the previous stents. But there was no, the stents previously implanted, cipher, showed no significant in-stent restenosis. RCA was okay. She was advised PCI then because of her symptoms and the strongly positive stress test, but she declined. And she also sought other opinions, and she was even advised to have CABG, but she declined. Now she returned the following year, 6 months later or so, on the 16th of April in 2017 when I saw her, and she had significant angina symptoms for about 2 months. LV function was still okay at 55, and the risk factors have improved somewhat. On the 17th of April, she agreed for an angiogram with a view to an angioplasty. And this was the angiogram procedure which I started after clinic at 5:45 p.m. And you can see here, she clearly has osteo-LAD disease, and the mid-circumflex disease have deteriorated, and the deterioration was just before her circumflex stent previously. So the circumflex was promptly treated, okay, after I've explained all the features and findings to the patient. So the mid-circumflex was stented with a DES. Then we move on to the LAD, osteo-LAD disease. It was initially dilated with a semi-compliant 2.5 balloon followed by a NC 3.6 millimeter to 24 atmosphere. And the osteo-LAD lesion looks slightly better, but it recoiled rather quickly. And you can see in the bottom that the stent of 3.5, 18 millimeters was unable to cross the lesion. So I have to dilate the lesion again, and this time using a bigger balloon, a semi-compliant balloon, longer and up to 12 atmosphere. Longer, I thought I have to stent into the left main anyway. I might as well smoothen out the tunnel and see whether the stent can go up. Unfortunately, the SEM stent 3.5, 19 or 18, 19 could not cross the lesion. Okay, so twice I failed to cross the lesion. Now, what else can I do? I put an anchor balloon in the circumflex, which already had 2 stents by now, and surely the stent advanced. Okay, and I deployed the stent, okay, to a 16 atmosphere. On the chart, it says 3.75 millimeter in diameter. Now, this was the result after my stenting. Now, I put down in red color there. That was what was in my mind when I saw this picture. I need to post-dilate this LAD, osteo-LAD especially, and then I will do a pot in the left main where the stent will be jutting in, okay? Now, can I ask the panelists, would you do a post-dilatation? And would you also do a pot in this lesion? Or would you say, okay, it's already 6 o'clock or 6:30, I want to go home? Would you leave it like this? Or would you do further improvement to this osteo-LAD? You would carry on and do what I have in mind? Would you, Dr. Lam Ho?
Depends on the IFAS. If it's not good, then may do something.
This IVUS thing, our friend there also said not everybody can afford an IVUS. In this case, we already have a deal, in the beginning. We will keep the cost to the minimum. Okay, so I look at it. I use my EYE IVUS. I look at it. I say, well, there is a problem there. It was very hard. Even the pre-dilatation show recoil very fast. They must have some calcium and fibrotic tissues there. So I decided I have to post-dilate. So I put a 4.4 times 6 NC balloon to post-dilate the osteo LAD. I didn't go up to high pressure. I just went up to 12 atmosphere. In the chart, it says 3.9 millimeters. After that, I need to go and do a pot inside the left main stem. Okay? And what happened to the pot? Oh, can you, let me see. Can I run this? Can you help me to run these angiograms? Oh, hang on. Maybe. Okay. I can click here. There we go. That was when I was positioning the balloon for a pot. And this was what I saw. And can you imagine? It's already 6:30 or something p.m. And I thought I could go home. Okay? So as I was positioning this 4 balloon for pot, I saw a huge, okay, at least you can say type 3 or class 3 perforation of the proximal LAD. Okay? And so I was thinking, well, it's just a perforation. So what? Okay? So I asked for a stent graft from the lab people, the technicians and the nurses. And what was the answer? No, we don't have one. There you go. Okay? Now, I was shocked, And what was the reason there was no stent graft in the hospital, in the lab? Why? Because of the recent hospital accreditation for JCI. And anything that is expired must be removed from the lab and the hospital. So we always have 2 stent grafts, but it was expired, so they were removed from the hospital because of the hospital accreditation. So I have to say at that time I wasn't very happy. So I have to tell off the cardiac manager and tell him, you have to get stent graft for me from the hospital's in Penang Island. So he started calling up all the hospitals. But bear in mind, that was already 6:30 p.m. Everybody have gone home, okay? And not many people were left behind. So he has to call some people at home even to get some ideas about where the stent grafts are. Anyway, other cardiologists have also left the hospital. Only the anesthetist on call was in the hospital. But anyway, I said, anybody, ask them to come. And the cardiac surgeon also has gone home, but he said he'll come in and have a look. What do I do? Well, this is the acute complication of a PCI, a main vessel perforation. And you can see here, this was my problem, main vessel perforation. It's not a distal vessel. And this is the algorithm for treating coronary perforation of the main vessel. And it's universal that we have to inflate the balloon to occlude the artery, and then we may have to give some IV infusion of fluid to help to push up the blood pressure and carry out pericardiocentesis if necessary. I've already informed the surgeon and looking for a cover stent. So this was what I supposed to do to follow the algorithm, and 4.6 millimeter balloon inflated, and not at high pressure, low pressure, 7, 8 atmosphere, trying to block this perforation. But you can see on the angiogram, there was still a leak, despite the fact that I inflated a 4 balloon at a 6 to 8 atmosphere at the site of lesion. So something is not right with this artery. And because the patient could not tolerate this long inflation, after 1 minute, she complains of angina. And you can see the ECG changes and so forth. Okay? And she'll be screaming about pain. And I have to deflate the balloon almost every 2 minutes for 10, 15 seconds to allow some degree of, perfusion and reducing her angina. And I went on like this for about 20 minutes, and then her blood pressure started to drop. I was still shouting for a stent graft, okay? But of course, cardiac manager has gone out to another hospital, another person has used a motorbike to another hospital to get this stent graft for me ASAP. And at the same time, because the blood pressure was, coming down, I have to prepare the patient for pericardiocentesis, okay? And 28 minutes later, for some reason, if you look at these 2 angiograms, has the bleeding stopped? It looks as if the bleeding has stopped, But maybe the one in the bottom, the spider view, may not have stopped completely. I get still a little bit of a flush, But I think actually it appeared like it has slowed down because of tamponading, because of a cardiac tamponade. A BP has dropped now to 90. Echo effusion now is 12 millimeter instead of 9 just now. And I already have taken out 150 ml of blood from the pericardial space. The inotropes have been started. 34 minutes after perforation, luckily, the graft master in 2016-17, it was a graft master a lot of hospitals have, okay, arrived. So we have a 3 millimeter, a 3.5 millimeter graft master. Pericardiocentesis has to carry out, blood pressure improved to 120, but there you go. I had a graft master here in this guiding catheter, and I could not deliver this graft master, okay? Even though this is 7 French guiding catheter. And her blood pressure suddenly crashed to 60. Basically, she arrested, okay, at 7:20 p.m. I spent about 4 or 5 minutes trying to get this graft master in. Obviously, during that time, I wasn't doing the ping pong technique. I have nothing to block the leakage, the perforation. So she may have accumulated a lot. And she developed asystole, and we have to carry out CPR on her. And, worst comes, bad things come in, not in single hand, but 2 hands. The wire and the guiding catheter all drop out during the CPR time, okay? However, we managed to reestablish her rhythm. Her blood pressure improved on inotropes to 95, and also continuous aspiration of the pericardial effusion. A 7 French guiding catheter I went to put back, but could not re-engage in. So I have to use a diagnostic catheter, 5 French, small catheter, to get into the left main stem. And I did 1 shot. What happened? I think there are lots of clots, but there's no flow in the left main stem, as you can see in the bottom angiogram. Okay? I think there may be a lot of clots. The expert panelists will see this, and I'll let you have a look at it a few more times. Is it clot or is it something else? You see? Okay? No flow. Anyway, I managed to wire down using this, through this diagnostic catheter. I put a wire there, and then extension wire. I managed to exchange this catheter into a AO1 guiding catheter slowly. Okay? And then through this guiding catheter, I managed to put a balloon there and dilated the left main stem. Okay? And after I dilated the left main stem, the flow was re-established about 7:45 according to the recording. But I wonder whether there was a dissection in the left main stem. Okay? It may be due to manipulation of the guiding catheter and so on. But unfortunately, the leak was also re-established. And then pericardial drain, another 120 mil. Okay? Finally, the graft master 312, okay, managed to cross, and I deploy at 8 p.m. And this graft master is really an awful master. Okay? It took a long time to deploy the stent. In fact, it took over 1 minute, okay, for the stent to expand, and eventually I managed to bring it up to 20 atmosphere in the proximal LAD. Now, you may look at the picture and you may think that my stent may be too distal. The proximal dot of my graft master is actually probably at the site of perforation. But actually, before I deploy this, I did manage to pull back a couple of millimeters or so, and then only deploy it. But after I deploy, because I think I have to inflate the balloon for over a minute to get to 20 atmosphere, the patient rearrested, okay? And we have to do the same thing. Massage and massage, okay? And after massage, with someone else's hand also, never mind, and you see there's a finger, I think that's a ring, okay? Moving there, I did a shot in the left main. I think there is actually a dissection of the left main. You probably can see now quite clearly the dissection. And it's still leaking blood from the perforation site. Terrible, okay? And I just also wonder still whether the stent graft was too distal still. Anyway, I put another stent in, DES, 3.523 now, from the ostium of the left main, again, to cross over, to overlap with the stent graft into the LAD, okay? And then I post-dilated using an NC balloon 3.5 from the left main stem all the way to the almost the mid-LAD, all up to 22 atmosphere, okay? Now I feel a bit better, okay? Because now it looks okay. Never mind about this circumflex, I said to the nurses, I remember. We have to save the LAD, okay? And you can see there's a little bit, still a bit of function there, pumping action there in the LAD territory. I said, never mind about the circ, we just wasted the circ, it's okay. And IABP was inserted, and the patient anesthetist was there during the resuscitation. She was already ventilated, and we transferred her to the ICU at 8:45 p.m. I'm supposed to be hungry that time, but I wasn't really hungry, you know. On ICU, on low dose of adrenaline and noradrenaline, her blood pressure was well maintained though at over 120. She was responsive mentally, you know, and she had a few runs of self-limiting VT, and however, this echo you can see there, the pericardial drain continued to have blood, okay? And the echo showed this persistent pericardial effusion, and I wonder whether there's still a leak, you know. It's basically like pouring blood out from that somewhere. So I decided to take the patient back 10:30 p.m. to the lab. What happened? I did semi-emergency angiogram. I did one shot, first shot, and the patient developed asystole. Okay? And we have to do CPR again. Okay? And luckily the CPR was successful. Okay? But can you see the leak coming out again? Yeah? Can you see the leak coming out superiorly just underneath the pigtail? Yeah? Now, I am stuck, you know. And What should I do next? I've already implanted 1, 2, 3 stents, almost 3 stents already in the left main to the LAD. And it's already almost 11 o'clock p.m. Okay. Anyway, this cardiac manager managed to get 2 stent grafts over. One was 3, the other one 3.5. So I managed to get the 3.5 in and really just put the stent graft in the left main at the bifurcation, into the LAD. And I post-dilated again using the same 3.5 NC balloon, this time to 24 atmosphere, okay, slowly. And I tell you again, the stent graft is such a bad stent. It took a long time to inflate and deploy it. Finally, I thought I have achieved successfully, there's no leak, okay? That's what I thought, okay? Anyway, the bleeding stopped. Actually, she had a stormy recovery course that night. She had VT attack, overnight and the next day, and was cardioverted 157 times, okay? I have to say the first 10, 20 times I used the defibrillator pad to put on her chest to shock her out of the VT. After that, I just put the defibrillator sticker pad on the chest and just press the button. And I keep telling the nurse, press the button will do. Each time she gets the VT. Did not respond to lignocaine, amiodarone, or magnesium. But finally, the next day, lunchtime, I managed to convert her or stabilize her using intravenous calcium. I didn't know that. In fact, it was a long shot in the dark. I said, just give her some calcium and see. Wow, the calcium actually stabilized her VT, okay? And I did an aortogram and angiogram, and you can see, okay, I did an aortogram just to have a look at the right coronary artery, and I selectively intubated the left coronary, and the left coronary now looks okay. And the echo, you can see now, got no pericardial effusion, okay? 4 days later, I removed the IABP, but her BP was maintaining on the 2 inotropes. However, 6 days after all this, she desaturated. And the x-ray showed consolidation. The hematologist was helping me to look after her because the platelet count was dropped. I don't know whether it's because of auto transfusion. I took out some of the pericardial blood, injected into her vein. I don't know whether that's the reason for some hemolysis and some low platelet count. Anyway, she became septic. White cell went up, fever, BP dropped, and she needed more inotropes. And then, unfortunately, about 2 weeks after the angioplasty, the ordeal of angioplasty complications, she developed multi-organ failure, renal dysfunction. Actually, she passed away about 2 weeks after the PCI. So, sometimes you can save them all. Most of the time you save them all. Rarely, occasionally, you may lose a patient. So, my take on this PCI-associated complications. Most frequently, the beginning of the procedure is the end also of the procedure. Extremely rarely, we hope rarely, the end of the procedure is the beginning of a very complex procedure. And this case illustrates this definition of what I meant by PCI-associated complications. So, just for discussion's sake, I look back on this case, I will never forget such a case, okay? What did I do wrong? Or what haven't I done? What have I forgotten to do? What should I have done, if I were to do it again? What else can I have done, you see? What about the initial preparation of the lead? And in fact, I think the best thing is, I put this slide on the, maybe we can just discuss with the panelists and the audience about some of these points that I have made here. Should I have performed a proper IVUS, rather than just using my eyes, my own IVUS, okay? And the graft master luckily is no more. We've got a better stent graft nowadays. And, and I said to the lab people, even an expired cover stent can save life. Don't throw them away, okay? And this graft master will, Anyway, my last slide was to tell you there is no greater danger than underestimating an opponent. And this is the famous Chinese Lao Tzu, okay? in his war strategy. So be prepared. Okay. Thank you very much.
Thank you so much, Dr. Lam Ho. We can share with the very tough case, and there are a lot of feeling. But I think we can learn a lot of the educational information from the case. And I can also thinking about very strong message from you. It is a never give up. But it is very interesting case. So may I ask our panelists have any comment or questions?
We always, it's like this, is a French philosopher, Voltaire, the best is the enemy of good.
So what would you have done? Would you have actually tell the patient, I must do an IVUS?
No, in fact, it's not essential. If you see the new score absent or the person or absent of IVUS, just 0.5 point only. It's not that important, but it's no matter IVUS or angiogram, you will see some imperfect result. Sometimes, if we do not pursue for perfect, then maybe.
Do you think otherwise, do you think I should have done a CT angiogram, CT coronary angiogram first?
Yeah.
Because, the artery was so, but then, she already has a strongly positive exercise stress test. I mean, I do a CT angiogram, usually if it were a CTO, you see, yeah.
And in this year, in TCDAP, I see one Singapore doctor present one similar case. They don't, I can't remember why they don't have the cover stand. They put 3 megatron, and then 3 megatron in the proximity, and then seal the perforation.
Yeah,
While
3.
I
really don't understand why was it so difficult, because, I mean, I actually put 3 stents in. Maybe I was guessing, in fact, I look at this angiogram probably about 50 times, 2 views. Did I miss the proximal? Did my graph master too distal, that it did not fully cover the perforation? But I did pull back. I remember I pulled back, but I didn't see it. Okay, I know that there was one shot I did. The perforation, was actually not completely covered by the stent, but I pulled back. A couple of millimeters. I should have covered. But this. Then I found out this graph master actually, the struts. You see, there is a cover portion up to 1.6 millimeter from the stent edge. So actually, your stent edge is not covered.
Yeah.
Only 1.6 millimeter inside the stent edge, then you see the cover. Okay.
Yeah.
So even if I pull back 2 millimeters, I'm just show this. Afterwards, maybe that's the reason why it was not fully covered, because the stent graft is so badly designed that there's a big gap, 1.6 millimeter between the 2 ends of the stent and the graft.
Yeah, and for graft master, is out of market now. Also, doing high pressure ballooning, while you expand the graft master, they will have foreshorten, 20% foreshorten in the.
It probably also foreshortened by 5-10%. Yeah, good point. So, yep.
Dr. Simon, very exciting presentation actually. I just mentioned that you're waiting for so long and that the two graft master to come to solve the problem. But at the beginning, you use the JL guiding catheter. You use the guiding. At first, you use the JL guiding catheter.
Which JR?
Yeah, JL.
You mean put another
yes.
guiding catheter?
No, because I asking you about why the graft master cannot reach the destination, because maybe the guiding catheter or because what reason? According to you, what is the reason?
We've
been waiting for so long, so we want this come to the destination as fast as possible.
Yeah.
So now it cannot go in the position, so it still take more time.
This graft master, the profile is so bad, so big, that when I have put stents in, when I try to push the graft master in, the guiding catheter comes back because I think the graft master is so big, the profile is just scratching, hitting the struts of the previous stents inside the artery. And so it refused to go in. Of course, nowadays we have a slightly better technique. If we got a guide extension, we can introduce the guide extension in, and then deliver the stent graft or guide master, whatever, and then pull back, pull back on the guide extension. That night, everything could go wrong, went wrong. You know, it took such a long time even to deliver a graft master. Partly also because my fingers may not be so good that night as well, you see. Sometimes we have bad days. Occasionally we have bad days. We hope it doesn't happen often. Yeah, really because the graft master was so big in profile, and I have a 7 French in, and I was trying to put a 3.0. I know their guideline is if it is 3.5 or less, you can use a 6 French. You can use up to 6 French. If it is more than 3.5 or 3.5 or more, you must use 7 French. Okay, and I had a 7 French. Okay, and guiding catheter, and it still could not support my graft master. I think actually the previous stents, struts of the stents inside the artery and the left main has provided some hindrance for the forward movement of the graft master. Yeah, and that delayed me a lot because I don't have another guiding catheter for the ping pong technique, you see. Or if I have an 8 French, I may be able to put another wire in and therefore another balloon into the LAD and block that first, and also serve as an anchor balloon whilst I advance the graft master. But that requires at least an 8 French guiding catheter.
Thank you, Dr. Simon. So I think it's a very interesting session. So because of time, so we have to stop our session right here for the next session. So again, I would like to thank for our 4 very excellent speaker, and also would like to thank our co-chair and our panelists here. So I think we have to close our session here for the next session. Thank you so much.
Thank you. Thank you very much.
Xin quý vị đại biểu cùng sẽ cùng nén lại và sau cái
Trong khi mà chờ đợi ban tổ chức cái lễ khai mạc thì chúng tôi xin công bố là năm nay đặc biệt. Bình thường mỗi năm mỗi phiên mà báo cáo các cái trường hợp khó chỉ có một giải nhất thôi. Nhưng mà năm nay thì đặc biệt là các bài báo cáo phải nói là quá xuất sắc. Thành ra ban tổ chức đã quyết định là cứ mỗi phiên vậy sẽ có 2 giải nhất. Rồi. Thì sau lễ khai mạc thì mình sẽ tiến hành cái lễ trao giải. Rồi. Normally, every year we give just one prize for each session of complicated cases. But this year, because the presenters are so excellent that we have decided that we give 2 prizes for each session of complication and difficult cases. Yes. And we will give the prizes just after the opening ceremony of the Congress.
Nói thôi bây giờ vô luôn.
Bắt đầu đánh trống trước đi.
Rồi đánh trống. Ủa ông hát biểu không? Và buổi khai mạc xin được phép bắt đầu ạ. Xin trân trọng cảm ơn các nghệ sĩ với tiết mục múa võ, một văn hóa rất là phổ biến của Bình Định đã mở màn khai mạc vô cùng hấp dẫn vừa rồi. Kính thưa quý vị quan khách, kính thưa quý đồng nghiệp, lời đầu tiên tôi xin thay mặt cho ban tổ chức hội nghị nhiệt liệt chào mừng toàn thể quý vị về tham dự hội nghị khoa học thường niên năm 2024 do Liên chi hội Tim mạch can thiệp Thành phố Hồ Chí Minh tổ chức. Xin gửi đến quý vị lời chúc sức khỏe, lời cảm ơn chân thành và lời chào trân trọng nhất. To all our returning attendees, welcome back, and your dedication and continued support are instrumental in making this conference possible, and we are grateful for ongoing commitment. And we also extend a warm welcome to those who are joining us for the first time. And over the next 2 days, you will become a part of an international community where everyone's voice is valued. You this chance to make the connection, ask questions, and share your experience with us. Kính thưa quý vị, theo định kỳ mỗi năm thì Liên chi hội Tim mạch can thiệp Thành phố Hồ Chí Minh sẽ tổ chức hội nghị mỗi năm một lần để chia sẻ và cập nhật những tiến bộ mới nhất trong lĩnh vực tim mạch nói chung và tim mạch can thiệp nói riêng. Và đây cũng chính là cơ hội để quý đồng nghiệp cùng nhau thảo luận, học hỏi và cùng nhau thúc đẩy sự phát triển của ngành y tế nước nhà. Và ngày hôm nay chúng ta gặp lại nhau tại Hội nghị Thường niên Khoa học năm 2024 tại thành phố Quy Nhơn, một trung tâm du lịch biển của tỉnh Bình Định. Và chúng ta hãy cùng dành một tràng pháo tay để chúc mừng cho cuộc hội ngộ lần này ạ. Đến dự hội nghị của chúng ta ngày hôm nay, tôi xin được trân trọng giới thiệu sự hiện diện của quý quan khách là đại diện của tỉnh nhà. Thứ nhất, giới thiệu ông Lê Quang Hùng, Giám đốc Sở Y tế tỉnh Bình Định. Sau đây tôi xin trân trọng kính mời thầy giáo sư tiến sĩ Võ Thành Nhân, Chủ tịch Liên chi hội Tim mạch can thiệp Thành phố Hồ Chí Minh đọc diễn văn khai mạc hội nghị.
Kính thưa quý vị đại biểu, quý đồng nghiệp, tôi rất hân hạnh được chào đón quý vị đến dự lễ khai mạc Hội nghị Tim mạch can thiệp Thành phố Hồ Chí Minh thường niên Hsic 2024 tổ chức trong 3 ngày, mùng 5, mùng 6 và mùng 7 tháng 7 2024 tại khách sạn Ania Premier, thành phố Quy Nhơn, tỉnh Bình Định, Việt Nam. Đây là một sự kiện quan trọng được đón chờ mỗi năm trong chuyên ngành tim mạch và tim mạch can thiệp của Thành phố Hồ Chí Minh. Trong bối cảnh bệnh tim mạch đã trở thành thách thức lớn nhất đối với sức khỏe và chất lượng cuộc sống của con người trên toàn thế giới. Tại Việt Nam, bệnh tim mạch cũng là nguyên nhân chính gây tử vong. Tuy nhiên, với sự tiến bộ của khoa học, các phương pháp can thiệp tim mạch ngày càng được cải tiến, phổ biến, góp phần làm giảm tử vong do nguyên nhân nguy hiểm này. Hội nghị Tim mạch can thiệp Thành phố Hồ Chí Minh Hsic 2024 là cơ hội để chúng ta cùng nhau trao đổi kiến thức, kinh nghiệm và các thành tựu mới nhất trong lĩnh vực tim mạch và can thiệp tim mạch. Qua đó, chúng ta có cơ hội cập nhật, học hỏi những phương pháp và công nghệ tiên tiến để cải thiện chất lượng điều trị cho bệnh nhân. Trong hội nghị này, chúng ta sẽ cùng nhau thảo luận về những thách thức và khó khăn trong việc áp dụng các liệu pháp tim mạch và can thiệp tim mạch vào thực tế, cũng như các giải pháp để giải quyết những vấn đề này. Một lần nữa, chúng tôi xin chào mừng tất cả quý vị
đang và sẽ có mặt tại đây và xin tuyên bố khai mạc Hội nghị tim mạch can thiệp thành phố Hồ Chí Minh Hsic năm 2024. Chúng tôi tin rằng với sự góp mặt của quý vị đại biểu, quý vị đồng nghiệp, Hội nghị tim mạch can thiệp thành phố Hồ Chí Minh Hsic 2024 sẽ thành công tốt đẹp, đem lại nhiều giá trị cho sự phát triển chuyên ngành tim mạch can thiệp và giúp bệnh nhân tim mạch Việt Nam có được chất lượng điều trị và cuộc sống tốt hơn. Xin chân thành cảm ơn quý vị.
Xin cảm ơn bài phát biểu của thầy giáo sư tiến sĩ Võ Thành Nhân. Và để tiếp theo chương trình sẽ là một cái tiết mục khá là quan trọng của tất cả các báo cáo viên ngày hôm nay. Đó là tiết mục trao giải Hsic Award. Và giải thưởng đầu tiên sẽ được công bố bởi giáo sư Võ Thành Nhân.
Chúng tôi xin công bố cái giải thưởng Hsic Award 2024 của cái phiên đầu tiên. Đó là Challenging and Complex PCI Cases. Thì có 2 giải nhất. Thì cái giải nhất đầu tiên là của bác sĩ Trần Văn Đông, Bệnh viện Tim Hà Nội, Việt Nam. Giải nhất thứ hai là của bác sĩ Banupong Rota của Bệnh viện Maharashnakan, Chiang Mai, ở Chiang Mai University.
Anh xin mời, cái này là em bắt đầu vậy này. Và sau đây chúng tôi xin mời hai bác sĩ báo cáo đoạt giải nhất bước lên sân khấu để ban tổ chức trao giải. Dạ xin mời.
So may I invite Dr. Trần Văn Đông and Dr. Panupong Rota to the.
Chúng tôi cũng xin mời phó giáo sư tiến sĩ Panipa từ Đại học Chiang Mai, Thái Lan, và xin kính mời bác sĩ Lâm Hồ từ Viện Truyền môn Hồng Kông cũng lên trao giải thưởng cho hai báo cáo viên. Dạ xin mời phó giáo sư Panipa và bác sĩ Lâm Hồ. Xin mời bác sĩ Lâm Hồ xin trao giải cho báo cáo viên.
For Hsic Award, we would like to invite Professor Panipa and Dr. Lam Ho to present presentation for two presenters today. Cảm ơn giáo sư tiến sĩ Võ Thành Nhân và các báo cáo viên. Và để tiếp theo chương trình, xin kính mời giáo sư tiến sĩ Phạm Mạnh Hùng lên trao giải cho các báo cáo viên ngày hôm nay.
Vâng, thay mặt session số 2 và cũng như giáo sư Võ Thành Nhân cũng đã tuyên bố thì chúng ta đều là những người rất là xuất sắc. Do vậy cho nên là gọi là so bó đũa chọn cột cờ. Cuối cùng thì cũng chọn ra 2 giải nhất. Chúng tôi xin vui mừng thông báo giải nhất thứ nhất thuộc về Dr. Phung Chun Yu ở Tim Muang Hospital, Hồng Kông. Và giải nhì thứ hai thuộc về Dr. Dương Thiên Bảo từ Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh. So, So the first slide for the second session about the PSI complication cases. For the two doctors, first belong to the Dr. Phung Chung Du from Twin Moon Hospital, Hong Kong, and the second for Dr. Dương Kiệt Lợi from Ho Chi Minh City University Hospital. Thank you.
Và tôi cũng xin kính mời Dr. Sozo từ Nhật Bản và cũng xin kính mời Dr. Simon Lo ở Malaysia xuống lên trao giải cho hai báo cáo viên xuất sắc. Xin kính mời.
I would like to invite Dr. Simon Lo from Malaysia and together for two presenters for today. Thank you and congratulations again for two presenters for today. Và để tiếp theo chương trình thì kính thưa quý vị, đồng hành cùng chương trình Hội nghị khoa học thường niên năm 2024 là sự góp sức hết sức to lớn của các nhà tài trợ đã làm nên thành công chung cho hội nghị, và ban tổ chức xin trân trọng giới thiệu và kính mời đại diện các nhà tài trợ lên sân khấu để nhận kỷ niệm chương của ban tổ chức. Xin trân trọng kính mời đại diện công ty Boston Scientific và Abbott là đơn vị tài trợ kim cương lên sân khấu để nhận kỷ niệm chương từ ban tổ chức. Xin kính mời giáo sư tiến sĩ Võ Thành Nhân sẽ lên sân khấu trao kỷ niệm chương cho nhà tài trợ kim cương. Xin cảm ơn giáo sư tiến sĩ Võ Thành Nhân và xin cảm ơn đại diện công ty Boston Scientific và Abbott. Tiếp theo tôi xin trân trọng kính mời đại diện công ty Alicia, Pfizer, Servier, SMT, AstraZeneca, Biotronic và Hoàng Đức là nhà tài trợ vàng lên sân khấu nhận kỷ niệm chương từ ban tổ chức, và xin trân trọng kính mời Phó giáo sư tiến sĩ Phạm Mạnh Hùng lên trao kỷ niệm chương cho các nhà tài trợ. Trân trọng cảm ơn giáo sư tiến sĩ Phạm Mạnh Hùng và các nhà tài trợ vàng. Và kế tiếp xin trân trọng kính mời đại diện của công ty Bayer, Boehringer, Biosensor, Philips, Anvi Medica, Viatris and Daiichi Sankyo lên sân khấu để nhận kỷ niệm chương từ ban tổ chức. Và xin kính mời Phó giáo sư tiến sĩ Huỳnh Văn Thưởng sẽ lên sân khấu sẽ trao kỷ niệm chương cho các nhà tài trợ bạc. Xin nhắc lại kính mời đại diện của các công ty Bayer, Biosensor, Boehringer, Anvi Medica, Beatrice and Daichi Sankyo lên sân khấu. Cảm ơn Phó Giáo sư Huỳnh Văn Thưởng và các nhà tài trợ bạc. Kế tiếp xin trân trọng kính mời đại diện của công ty Edward, công ty Novartis, Trọng Tính, Be Proud, công ty Bước Tiến Mới, công ty Thermo, công ty Medtronic và công ty Siemens lên sân khấu để nhận kỷ niệm chương từ ban tổ chức ạ. Và xin trân trọng kính mời Phó Giáo sư Tiến sĩ Hồ Thượng Dũng sẽ lên trao kỷ niệm chương cho các nhà tài trợ đồng. Và phần đóng góp không hề nhỏ khác của các công ty đến từ công ty Sanofi, công ty Việt Tường, công ty Marine, Gigamed, Merck, Hạnh Nguyên, công ty IDS, công ty Translumina, NQ Healthcare Australia, công ty Kim Hòa Phát, HPS và Nipro là các nhà tài trợ khác cũng lên sân khấu để nhận kỷ niệm chương từ ban tổ chức. Và chúng tôi xin trân trọng kính mời Phó Giáo sư Tiến sĩ Trần Văn Huy, Phân hội Tăng huyết áp Việt Nam lên sân khấu để trao giải kỷ niệm chương cho các nhà tài trợ. Xin nhắc lại đại diện của các công ty Sanofi, công ty Việt Tường, Marine, Gigamed, công ty Merck, Hạnh Nguyên, IDS, Translumina, NQ Healthcare Australia, Kim Hòa Phát, HPS và Nipro lên sân khấu ạ. giáo sư tiến sĩ Trần Văn Huy và các nhà tài trợ. Kính thưa quý vị, trong những ngày diễn ra hội nghị, từ ngày 5, ngày 6 và ngày 7 tháng 7, chúng ta sẽ có cơ hội lắng nghe những bài thuyết trình, các bài báo cáo khoa học từ các chuyên gia hàng đầu và tham gia các phiên thảo luận chuyên sâu và chia sẻ các kinh nghiệm thực tiễn. Tôi tin rằng với tinh thần hợp tác và học hỏi lẫn nhau, chúng ta sẽ gặt hái được nhiều kiến thức quý báu và có những đóng góp thiết thực cho sự phát triển của lĩnh vực tim mạch can thiệp. Chương trình chi tiết tại mỗi hội trường có thể thay đổi một chút so với thư mời. Xin quý vị tham khảo bản chương trình trước mỗi hội trường để tiện theo dõi. Và bây giờ xin thay mặt cho ban tổ chức, tôi xin tuyên bố bắt đầu chương trình hội nghị và xin chúc hội nghị thành công tốt đẹp. And again, thank you for your being here to become a part of the journey, and we'll enjoy for the access. Thank you again, and we'll see you for tomorrow and enjoy for dinner. Thank you so much.